Ankita,
yes,
are you
sir.
there?
Yes, sir.
Yeah.
Yes, ma'am.
Yeah.
Yes, ma'am.
Recording in progress.
We are starting the recording also. Okay. All right. All right. So good evening and welcome to one and all. I'm Ankita from Planet, the designated session assistant for a seamless experience. And Planet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Planet is very proud to be a digital partner for this event organized by Indian Society of Anesthesiologists, Borivali. And topic of today's session is regional anesthesia. So let's begin today's session, for which I would like to invite Dr. Yogen Bhatt to take over. Over to you, sir.
Thank you very much. Good evening to all the friends. I see all names which are known to me on the screen. I'm so happy to see them all. I'll just take 2 minutes to introduce the topic today. Way back in 77, when I joined the Department of Anesthesia, all old people talk like that, you know. So those days, the only local anesthetic available was lidocaine. And the time in which that lidocaine will stop acting, the residents would not even start their surgeries. Action used to be haphazard, it used to hardly act. The action was never sufficient to finish the surgery. A time came when I gradually stopped giving regional anesthesia and I migrated towards general anesthesia. But thanks to listening to the talks in Aura and Bala Venkat's meets and our own regional meets and focus and all, I am gradually seeing the younger members in my team giving regional anesthesia so lovely that gradually, simply by watching the screen and activities on the screen, I have learned a lot. I have again regained my things. And yesterday we gave a lovely brachial plexus block under a USG guided, and then I got opportunity to do adductor canal block also at 3 levels, which was recently taught to me by Dr. Kalpesh. I really thank this younger generation for keeping me updated. I'm glad to have you all with me. I think we'll start the full session now. Dr. Shilpa, you can now ask the next person, the team, to start going ahead. Thank you very much.
Over to Dr. Tendulkar.
Yeah. Good evening, everyone. I thank Anaesthesia TV's Mr. Chaube. Thanks to them, we are live on Anaesthesia TV. I also welcome Dr. Pinakin Gujjar sir, who is our MMC observer today for the webinar. I request ClearNet people to flash the CV for Dr. Harshal Wagh, who has been our who will be our moderator for today's talk. Dr. Harshal Wagh is a consultant anesthetist at Kokilaben Ambani Hospital. He is a AORA Regional Anesthesia Fellowship mentor. He has a special interest in regional anesthesia, obstetric anesthesia, anesthesia for oncosurgeries and robotic surgeries. And he has multiple publications in national and international peer-reviewed journals, as well as Indian Journal of Anesthesia. Over to you, Harshal. Dr. Harshal?
Yes, sir. Thank you very much for that kind introduction. I think we need to introduce the Dr. Amit and Dr. Hetal as well, sir. So, Dr. Shilpa, I think who's going to introduce?
Yeah, Dr. Rao, sir, can you introduce Dr. Amit Dikshit, sir? Ankita, can you share the screen?
I will introduce Amit Dikshit, sir.
Okay, okay. Dr. Neelam, madam, can you introduce Dr. Amit Dikshit?
We have the slide, please. Good evening, all. It is indeed my pleasure to introduce Dr. Amit Dikshit, sir, to you. Dr. Dikshit is at present working as consultant anesthesiologist at Ruby Hall Clinic, Pune. He is a course lead for Regional Anesthesia MUHS Fellowship. He is also a course lead for AORA Fellowship. Dr. Dikshit is a member of Board of Studies, AORA India Fellowship. He is also a member of Perioperative Intensive Care. Dr. Dikshit is a course coordinator for several workshops on basic and advanced echocardiography. He has contributed videos in Focus Today app. Focus Today app is an initiative by National University Hospital of Singapore. Dr. Dikshit has contributed chapters in regional anesthesia and focus handbook by Springer publication. We all welcome you, Dr. Amit Dikshit, sir.
Thank
Rao,
you.
sir.
Rao, sir, can you introduce Dr. Hetal Vadera, sir?
Can I have the slide, please? It's my privilege to introduce Dr. Hetal Kumar Vadera.
He is presently the head of the department of anesthesia at Sterling Hospital, Rajkot. He practiced as freelance anesthesiologist from 2000 to 2009, attached to Sterling Hospital from 2010 till today. His clinical interests are regional anesthesia, neuroanesthesia, bariatric anesthesia, with a special interest in creating awareness about CPR. He has many honors and awards and publications to his credit. He is a mentor at ERA Fellowship, awards at GRC Education Initiative Award 2018, 6 publications about regional anesthesia, and is invited faculty at many state and national conferences and workshops. We welcome you, sir.
Thank you very much, sir.
Tendulkar, sir.
Hello.
Yeah.
I invite Dr. Hetal, Dr. Harshal Wagh to take over the proceedings.
Thank you, Dr. Tendulkar, and thank you to ISA Borivali for organizing this webinar. I think I don't think there are any better speakers to talk upon this subject of abdominal wall blocks and chest wall blocks. I myself have learned a lot from Dr. Amit and Dr. Hetal and continue to do so. We won't waste too much time. So I think the flow of the session is going to be Dr. Amit is going to open the session with the anatomy and abdominal wall blocks. Then Dr. Hetal will take over with the blocks per se. Then Dr. Amit will again talk about the anatomy as related to the chest wall blocks. And then Dr. Hetal will take over the blocks per se. And then we'll take it from there. So if I may kindly invite Dr. Amit Dikshit to start sharing his screen and take over, please. Thank you.
And just a little interruptions, everyone. Before Dr. Amit sir proceeds, I would request everyone to mute themselves, and I am muting everyone to avoid any type of technical glitches. And sir, you can proceed.
Yeah.
Amit, sorry, before you do that, anybody wanting to?
You're on mute, sir. You're on mute.
Harshal, unmute yourself. Harshal, unmute yourself.
Sorry, I'll say that again. For all the listeners, if any questions, kindly put in the chat box and we will ask them at the end of the session. Thank you. That's for me.
Yeah. Thank you, Harshal, for this kind introduction. I'm really glad to be part of this team with ISA Borivali. I have been there previously. We did one workshop as well, focus workshop as well with them. And it's really nice to be part of this team again. I would like to thank the president, Dr. Yogen Bhatt sir, secretary, Dr. Shilpa madam, treasurer, Dr. Swapna, and the scientific secretary, Dr. Rajesh Rao sir. Dr. Neelam madam, thank you very much. I'm really happy to have very senior mentors today attending this session from Mumbai. I am an alumni of Sion Hospital and I worked in Hinduja and Lilavati. So I was good long 10 years there in Mumbai. And I'm really happy to have Pinakin sir and Ganesh Tendulkar sir here as a part of our team. And of course, my good friend Hetal and Harshal, who are part and parcel whenever there is any conference, we share everything, we teach each other and we learn from each other's experience. So today, of course, is an interesting topic. Dr. Shilpa called me some time back and she said, why the interest in regional anesthesia as regards to abdominal wall and chest wall block is decreasing. We should do something about that. Like something like, are everyone giving TAP block, ESP block, PEX block? What has happened to that? So I think this is then the idea of coming to this area, especially, I think this is probably the first webinar of its kind where we are dealing with chest wall and abdominal wall blocks, and that too with landmark and PNS. So this is an exclusive topic and it's a very interesting topic as well. So greetings to you all from my hospital, Ruby Hall Clinic. It's a 750-bedded multi-speciality hospital. When I joined Ruby Hall, it was 10, 12 years back, and that time we were not having ultrasound machine. And then we purchased a new PNS machine to start with. And then our journey started. We used to share a machine with radiology department. And then slowly we got now 5 ultrasound machines, and we also have regional anesthesia fellowship. Now this is our 6th year of fellowship. We have 3 students, 2 of MUHS and 1 of AORA. And I'm really glad that I am fortunate to have good exposure of training in my fellowship training at Ganga, where I was trained into PNS guided blocks by Dr. Bala Venkat sir, and also into landmark guided blocks by Dr. G. Venkateshwaran, who is a direct disciple of late Dr. Ravindra. So because of this, I think much of my work is influenced through the practices of Ganga as far as landmark and PNS guided blocks. And as we have slowly evolved, we have moved more and more into ultrasound. But of course, the regional block with PNS and with landmark do have a role. Sometimes when the machine is not there or in resource limited setting. So some of the disclosures which I have to make today are I have used 3rd edition Hadzik for most of my references. I wanted everyone to carry some take-home messages today. So anatomy slides, I want to keep it really simple. You are the judge and you only let me know how it was. I have used quite a bit of Nysora photo gallery images. I initially thought of using my own photos, videos. I have used them quite a bit, but those Nysora efforts and even our AORA society is also coming up with good photo gallery. So we are in the process. The purpose of my presentation today is to simplify to an extent that beginners should have a good take-home message. And at the end of this session, they should have some confidence to do these blocks without causing complication. I'll be showing some volunteers and photos of my patients for which I have taken consent. Ganga training has impacted my landmark and PNS, so there can be a bias as far as when I say a specific method is better, it is because I have seen and I am trained into that method. And regional blocks with PNS and landmark, those anesthetists who are doing regional blocks with PNS and landmark technique, I have great respect for them because frankly speaking, I have gone through the whole journey. And as I know, PNS guided block, a person needs to be a regional anesthetist with some specific personality. I mean, a person should be introspective, meditative, the hand should be rock stable, the needle should not move. So PNS guided block really needs good knowledge of anatomy. I'm not saying that with ultrasound, we do not require that, but definitely the ultrasound blocks are easily reproducible, whereas PNS will definitely require some bit of training. And therefore, those of us who are practicing PNS and landmark blocks, I'll be learning from every one of you more and more, and I have great respect for you all. So with this note, I'll start my first part of the presentation. Before embarking on directly on the interfacial plane block, anatomy, I thought initial few slides on what is the rationale of interfacial plane block I should discuss. So interfacial plane block overall, if you look at the history from 2009 onwards, we could see a rapid rise starting from TAB block, rectus sheath block, and then the Rafael Blanco with his PEG block and SAP block, and then we have QL1 and quadratus lumborum 1, 2, 3, and it all continued. So whenever there is a nerve, we can always block it with probably PNS, but interfacial plane block became much more popular because of use of ultrasound. So of course, Dr. Hetal Vadera will be showing us his interesting videos with all landmark technique. and his way how he does it. So these will be some tips and tricks, but the complexity of block increases when there are anatomical variations, there are vessels, then probably the ultrasound can be a better bet in that case. So there are some limitations with landmark and PNS guided technique, especially for interfacial plane block, because here we are opening one plane and not targeting directly on the nerve. So move on to that. So how we have evolved. So initially, probably like 20 years back, it was more of IV and opioid PCA, रात को morphine, yeah, Fortwin, and Buell patch. Even today, those who are not trained in regional anesthesia probably depend on this type of modality. But of course, then it requires some bit of monitoring, oxygenation, problems with opioids. We all know respiratory depression, urinary retention, pruritus, nausea, vomiting. So we are slowly moved from systemic analgesics to something like more and more peripheral. So we have moved towards local anesthetic at peripheral nerves, and then add to the the LIA mixture. So what is the buzzword? The buzzword today, where the regional anesthesia is progressing, is loco-regional opioid sparing. Yeah. So whenever possible, give local infiltration. Whenever possible, give a peripheral nerve block. Whenever possible, do opioid sparing. Motor sparing, as the adductor canal and other blocks, we are having motor sparing block. Then site-specific block. And if surgery is in one limb, why to block? If surgery is in one breast, why to block other side? Something like that. Procedure specific. If patient has undergone thoracotomy, the plan is different. Breast mastectomy, it is different. And multimodal analgesia. So we want to use this principle. How far we can succeed, we don't know. But we, in our routine practice also, we are using it. And therefore, I'm just sensitizing you all with this multimodal regimen. In pre-intubation, many of you have had this thesis topic nowadays, and people are using it. Use of Xylocard and magnesium sulfate and oxygen subanesthetic dose of ketamine, and intraoperatively dexamethasone, dexmedetomidine, NSAIDs, and near extubation LIA and Xylocard and paracetamol. So I'm not overemphasizing, but all these interfacial plane blocks will definitely act in a better way with multimodal analgesia. So now what is the bias about the interfacial plane block? I was just going through a few of the questions which Harshal also forwarded us. And the bias is because of the mechanism of action of interfacial plane block. Now, this is a separate topic, and nowadays a topic of seminar also, where what is the exact mechanism? Because in interfacial plane block, we open up the interfacial plane and we think probably all those spinal nerves, the ventral and dorsal rami, which are traveling through that interfacial plane, probably will get bathed and we will have analgesia. Some initial studies were showing that probably the drug is moving posteriorly and it is with indirect paravertebral action. But now, still after a lot of research, we came to know that anatomy may not give us complete answers. The answer could be at molecular level, because the exact mechanism of action of interfacial plane block is still being discussed in all the conferences. It could be intravenous absorption. It could be like not intravenous, sorry, systemic absorption, or by its action on sympathetic neuronal element. So there are multiple mechanisms. So here we are not targeting a nerve, versus when it comes to brachial plexus, it is like directly a block on the nerve. So here, when we are talking about spinal, epidural, or a brachial plexus block, they are meant for surgical anesthesia, and they are exactly, we are blocking and attacking the nerve per se. When we talk about interfacial plane block, say for example ESP and TAP, I have put it because it is very common. Here we are not exactly targeting the nerves. It is through indirect action. Probably the drug sips, it may cover the nerves in that plane, and it is volume dependent, and it is so we have to anticipate the action will be different. So when it comes to brachial plexus or a spinal or an epidural assessment, it is all or none law. Block act hua, nahi hua. Spinal act hua, nahi hua. Whereas interfacial plane block, there is, when people are assessing it with the mindset how they use it for spinal and epidural, they think that it is partial action, but it is not so. It is not at all a partial action. So if Wagh score is of 9 and you do a brachial plexus block or a spinal and an epidural, it is brought to 0. But if interfacial plane block is done and Wagh score from 9 to 5, it is still a successful block. This we have to understand, because those who start with enthusiasm, PEX block or TAP block or ESP block, they said, oh, block to diya, but it is not acting. Because our endpoints, we think that it should act like an epidural, it should act like a spinal, it should act like a brachial plexus block. It will never happen. So a dent from 9 to 5 is a very, very successful interfacial plane block, which when supplemented with multimodal analgesia will work wonderfully well. So one essential thing, the brachial plexus block or the spinal epidural, whenever nerve is blocked directly, it is meant for surgical anesthesia. If we reduce the concentration, it can be for post-op analgesia. But interfacial plane block, we are not directly blocking any nerve. We are opening the interfacial plane. Therefore, they are meant for post-operative analgesia, and they are not ideally meant for surgical anesthesia. So somebody was asking, can we do cesarean section under TAP block? Can we do mastectomy under ESP block? Something like that. So the answer, probably the first answer is no. But in those high-risk patients, there are case reports that people have, they got away with use of this block along with multimodal analgesia, along with local infiltration, along with a very cooperative surgeon. And because no other options were available, GA was very risky, spinal epidural was very risky, and even we have done secondary suturing under ESP, vertebroplasties under ESP, even the CAPD catheter insertion under ESP block. So this can be a very good adjuvant to whatever existing modality. It may reduce the anesthetic requirement, but they are not really meant for surgical anesthesia. So there is a clear-cut dermatomal marking. If I have done an epidural, we can see the sensory level exactly, say T9, T10. But whereas interfacial plane block, it again depends on how the drug has moved, how the interfacial plane has opened, and it could be a vague distribution. So you will have a variety. So we just check the block in the end with cross mark with a hot or cold. You can use ice and see if there is hypoesthesia in the desired area, and you can mark them. So you will know this was a case of bilateral ESP block, and we have checked where the drug has gone, and it was probably done at around T8-9 level and bilateral ESP block. And we could see that there was hypoesthesia when we compared with leg and hand. The patient could say. So we have to assess all our TAP, all our ESP block, all our PEX block before we declare that block has not acted. So we have to check if there is any hypoesthesia or not. And therefore, it can reduce the analgesic requirement. Interfacial plane blocks are good adjunct to multimodal analgesia, and they can achieve better results with ultrasound because you can see more of anatomical variation. Sometimes elderly patient, you may not get exact pop. So of course, these are some tips and tricks which Hetal will be sharing with you in some short time. And literature evidence, if people are asking about the evidence, interfacial plane blocks have come into all these have got invented after 2010 onwards. So interfacial plane blocks literature is just 10-year-old. When you talk about spinal, epidural, and brachial plexus, we have a very big history. So with most of the meta-analysis, when they are compared directly, with say epidural or paravertebral, the evidence is much higher, the Cochrane database and everything. And interfacial blocks, plain blocks are still emerging. And slowly we are finding, we are discovering the proper indications where we can use it. So now today we are discussing this topic with the help of Landmark and PNS. So we are talking about resource limited settings, and definitely PNS is beneficial even in interfacial plain blocks. Hetal will be demonstrating, because there are nerves near the vessels which can be stimulated very well, something like a pectoral nerve or ilioinguinal, iliohypogastric nerve. And if you have ultrasound, it is well and good. So the purpose is it is an adjuvant, it can fast track the analgesia. And now some new challenges are being addressed with these interfacial plain blocks, because they are safer alternative in a hemodynamically unstable patient. Say patient with hypotension, we can still give ESP block or a TAP block. Patient with borderline coagulation issues, we can still do some superficial, interfacial plain blocks. Patients with high counts, patients with instrumented spine deformities, obese patients. I'm sure. Now, what is the friend of Landmark technique? It is bone. Definitely for ESP, we have a bony Landmark. For serratus anterior plain block, again, we have a bony Landmark. Even for a paravertebral block, we have a bony Landmark. So bone is a friend, and even in obese patients, we can do them very with good success rate. So with this short introduction, we need to know more and more about the anatomy to get our block right. The newer avenues which we have started utilizing is on-arrival for fracture ribs, something like a ESP block or a block in the ICU, or rescue block for breakthrough pains. Epidural has come out, then we have done an ESP block. Even the rectus sheath block for a laparotomy as a rescue block. So even we have used, I'll be showing few slides where we have used ESP for MRI as well. So coming to the basic topic of anatomy of abdominal wall blocks, I was just thinking and contemplating how anatomy, which anatomy is really relevant to the beginners. I have looked at literature. I thought I will not complicate the topic with covering more and more variations and cadaveric dissection, because I have made this presentation relevant to today's audience, where they can have some quick take-home message. And therefore, I have decided that I will just showing 4 slides for each block. You need to know the gross anatomy, where the block is being performed, at what part of the body, and what should be the ergonomics. Second, I'll be touching on the sonoanatomy, because you need to know what are the muscles there. I'll be showing slides on schematic anatomy and the nerves which are getting blocked.
So, learned a lot from Dr. Amit and
basics
Dr.
first, and the nerves which are getting blocked.
Ankita, please make everyone mute. Ankita,
basics.
Please make all participants mute. Amit sir, you can continue. Sorry.
Yeah. So whenever there is any nerves which are getting
Ankita, please make everyone
not
mute.
about whether I can give block or not. It is a strategy. It is a regional anesthesia strategy, which I have initially mentioned, the how you perform and how you use. So it could be, say, for breast surgery. If it is for surgical anesthesia, I can use combination of multi-level paravertebral with PECs 1 and 2. I may use pectointerfacial or parasternal blocks. I may use supraclavicular nerve blocks, depending on the dissection area. So we need to know what are the osteotome, myotomes, and dermatomes. And at least we should have some good working knowledge as what is the area of dissection. Now, if you look here, the anatomy, and as we have divided the topic as upper trunk and lower trunk, or chest wall blocks and abdominal wall blocks. So by and large, if you see, the chest wall and abdominal wall are not exactly similar, because on the chest, we have what is called as a breast tissue. And you can see the innervation of breast is long thoracic nerve, this nerve to serratus anterior, nerve to latissimus dorsi, pectoral nerves. All these are branches of brachial plexus. So now when we are talking about strategy for chest wall, we have to take into account the brachial plexus component. Whereas with abdomen, we just have to address T6 to T12, which is more of a thoracic spinal nerves. So this difference we have to take into account when we plan our analgesia strategy. So probably the challenging aspect could be the thoracic block to have good quality of analgesia, and sometimes the upper abdominal part, I would say T6 to T8, this also becomes challenging. Of course, we will be discussing about the subcostal tag block and little bit about the external oblique intercostal facial plane block also. Because of the diaphragmatic splinting and respiratory effort, this area again became very, very challenging. So let's see how we can help our patients. So we need to know these chest wall blocks or abdominal wall blocks. We are basically trying to block the spinal nerves. So they are dorsal rami and the ventral rami, and these are the intercostal nerves. And we know its course in the intercostal groove, and at the lateral, at the mid-axillary line, it gives a lateral cutaneous branch, and then the terminal branch on the chest near sternum or in the abdomen near the rectus sheath as the anterior cutaneous branch. So here the important point is the lateral cutaneous branch, which is jetting out, which is getting formed at around mid-axillary line. So whenever a block is done anterior to mid-axillary line, we may probably miss this branch. And once this branch is missed, probably the lateral aspect of chest and abdomen is not covered. So when we are doing, say, SAP block, or when we are doing, say, TAP block, we have to go as posterior as possible. We should not be anterior to mid-axillary line. So intercostal nerve anatomy is very, very crucial. At mid-axillary line, the intercostal nerve gives rise to lateral cutaneous branch, supplying the lateral aspect of the abdomen. And intercostal nerve terminates as anterior cutaneous branch, supplying the anterior skin and muscles of anterior chest wall and abdomen. It comes to both, the spinal nerve behaves similarly with chest as well as abdomen. So the lateral component or the terminal anterior cutaneous branches are similar, and they supply the respective area. So let us start with TAP block. I'll be just showing 4 slides. First, you need to know what all spinal nerves. We have to do it at bilaterally. We'll try to cover T6, T7, T8, and probably T10, 11, 12. And so we'll start with a lateral tap, which is a very commonly done tap. Now I'll be just highlighting the key aspect. So it is the ipsilateral cutaneous innervation, especially T10 to T12 dermatome we are looking at. So I'm thinking of all those C-section patients where I can have very good post-analgesia as a part of multimodal regime, and patient are L1 is not consistently blocked. So what is the area of L1? Those are like inguinal hernia incision, the groin incision. So L1 area is not consistently blocked. I'll just show you. This is the L1 area. So that's the groin area. It is not consistently blocked with the lateral tap. So where is the lateral tap? We place the, so I'm just letting you know the position of the patient. I'm letting you know the ultrasound image because we need to correlate that when we are doing with landmark or a PNS guided block. So this is the area where our block is getting done. And what we need to know, once we place the ultrasound, we actually see all these 3 muscles, the external oblique, internal oblique, and transversus abdominis. And the drug is deposited between the plane of internal oblique and transversus abdominis. So this is a schematic diagram which shows how we have skin, subcute, external oblique, internal oblique, and transversus abdominis. And Hetal will be demonstrating the pops and clicks, and first pop, second pop, and how we try to reach at this level. Now, anatomical tip, as I have already highlighted, the ventral rami gives the lateral cutaneous branch which innervates the lateral abdominal wall at mid-axillary line. So do not perform this block anteriorly or at the anterior axillary line. Go as posterior as possible, at least at mid-axillary line or posterior axillary line. I'll be talking about the subcostal tap. And here is an important point. When we want to block the subcostal, why we want to block? Because the lateral tap is not covering, that T6, T7 and T8 area. So we have to place the probe in the subcostal area. Now, when you have to understand, when the needle injection is done medial to linea semilunaris, so we have linea alba in the midline, and then we have linea semilunaris. So when the needle injection is done medial, on the medial side, then it covers more of T6, T7. And when it is done lateral to linea semilunaris, then it probably covers T9 to T10. Whereas the skin, as I have already highlighted, lateral aspect, because it is not covering the lateral cutaneous branch, so it will not cover the lateral aspect of abdomen. So where are we placing? So it is in the subcostal area. This is the area of interest, and this is the anatomy which we need to know what is down there and how we place the probe. So it is somewhere, so midline is the linea alba, just lateral to it where rectus sheaths just ends. I'll be showing on sonoanatomy as well, is the linea semilunaris. Medial will cover more of T6, 7 and lateral will more of 8, 9. So this is the place where we have rectus abdominis muscle, which has just ended, lower down the transversus abdominis, then the internal oblique and the external oblique. So in this area, the middle area, we can deposit drug, and we expect that drug to move in both directions, one on the medial side and one on the lateral side. So in a schematic diagram, this is courtesy Nysora, and it's a really good website. You can understand, even Dr. Admir Hadzik has promoted this Nysora continuing education and all his slides. This is, they call it as reverse sonoanatomy. And this is rectus abdominis, internal oblique, external oblique, and the transversus abdominis, and how the drug is getting deposited. So rectus sheath block, then subcostal tap block, all these are in continuation. So rectus sheath, then lateral continuation is a tap plane, how the drug is moving ahead. I'll be covering the posterior tap block. The important thing is ipsilateral cutaneous T9 to T12 innervation. So this is mainly definitely covering the lateral abdominal wall between the costal margin and the iliac crest. Where is the anatomy necessary? We want to see the anatomy is, you can make the patient lateral, and between the rib cage and the iliac crest, we can definitely see. So as we go more and more posterior, the original description by Raffi of the tap block is actually a quadratus lumborum block, which has provided visceral component of pain relief as well. Now, here is external oblique, internal oblique, and transversus abdominis, and we try to deposit the drug between the internal oblique and the transversus abdominis. So I'll be showing you here. So this is the area for the posterior tap. Now, if the needle is punctured a little bit more, and if it has pierced the aponeurosis of transversus abdominis, then probably the drug will go into the fascia transversalis, which is just the layer lining beneath the transversus abdominis, and then below is the peritoneum. So once the drug reaches the fascia transversalis, it is a QL1 block. Sometimes even if we deposit the drug here, by virtue of volume and diffusion, the drug may diffuse down, and it can produce visceral component of pain relief. Otherwise, the tap and rectus sheath block has one limitation, that they will provide only the somatic component, and we have to supplement some amount of opioids or other multimodal analgesic regimen to have good analgesia. Now, ilioinguinal iliohypogastric nerve, I am addressing because now we are talking about PNS guided block. Whenever there is nerve, we can always stimulate that. And it will, when we specifically aim for iliohypogastric nerve block, it will cover the L1 dermatom over the inguinal area. So you can see near the ASIS, and I'm trying to look at the anatomy. What is the anatomy? I think some of you can use the rubber here, and they can remove all these scratch marks as well. if I may request, not to use the annotation. Yeah. So when we use ilioinguinal and iliohypogastric, I just want to look at what is the position of these two nerves near the ASIS. And what we see here is the anterior superior iliac spine, and from where the external oblique has become aponeurotic, then we have a bigger belly of external oblique, the internal oblique, and below is the transversus abdominis. So in the same tap plane near ASIS between internal oblique and transversus abdominis, we have these two hypoechoic areas, which are ilioinguinal and iliohypogastric. We can definitely use PNS here. And this is the reverse sonoanatomy vessel and deposition of drug. Now the rectus sheath block is being used for midline.
Amit, sorry, one second. Can I request whoever is to kindly mute?
Yeah, Ankita, why aren't you muting immediately, please?
Also, I think
I'm muting everyone. Once they are creating any problem, I'm muting everyone, but it needs a little time actually.
So no, Ankita, what you have to say, you have to tell the speaker, sir, I'm muting everyone, then you unmute yourself.
Okay, okay.
Yeah, you can mute me. I can see it clearly on my screen, so I will use that option. No problem.
All right, sir. All right.
Yeah. So
I'm muting everyone again, and just so you can. Okay.
So nerves are located in the space between rectus abdominis before giving out anterior cutaneous branches. So I have already highlighted the course of a spinal nerve, and how these intercostal nerves, and when they come on the anterior side, they give terminal branches, which are the anterior cutaneous branches. And before they form this anterior cutaneous branch, they lie in the space between rectus abdominis and the posterior rectus sheath. And therefore, we can definitely block them. It is surely a somatic block, not covering the visceral component of pain relief. And what are the indications? We have even used it for midline laparotomies. Especially, it is beneficial in patients with periumbilical, umbilical hernias from T9 to T11. So these are some robust indications where we would definitely like to use. Some patients with spinal deformity or operated case of spine, we have placed bilateral catheter, and it has wonderfully worked for midline laparotomies as well. So this is the rectus sheath. Here the probe is being placed on linea alba, and what we see here is a nice big rectus muscle, and it has a posterior rectus sheath and a fascia transversalis, and of course the peritoneum. So this is the anatomy, where schematic anatomy, where we can see the rectus muscle. We just have to deposit the drug. When the drug is nicely opening up the plane, you will see the elliptical spread, which is seen with ultrasound. And whenever it is an intramuscular injection, it will just create a bleb in that muscle, as if the muscle is swollen. So it will not have an elliptical spread. Sometimes some of the nerves, just like we see in adductor canal, the nerve to vastus medialis is intramuscular. Sometimes this ilioinguinal, iliohypogastric also may be within the substance of muscle. So of course, when we use PNS, we may or may not open up the plane correctly, but definitely when we get a response, which is an end motor response, and we are targeting the specific nerve, I think the quality of analgesia is much better than using it absolutely with landmark. So even I have stimulated the ilioinguinal, iliohypogastric and the pectoral nerves, and we always feel confident with that block for sure. So this brings to the end of the first half of my presentation. I've already highlighted that evaluation is must. Sometimes when we have done a bilateral tap and we have not evaluated for whatever reason, like patient is under spinal and we have not met the patient later, but it is absolutely necessary whether there is hypoesthesia or not. Sometimes it may be one-sided block may be acting well, other side may not be acting well. So before labeling that block has not acted, we should be very much sure that we have done the block correctly. Everything has got a little bit of learning curve and we have to practice it. And I'm handing over the further proceedings to Hetal and Harshal. Thank you very much.
Thank you, Amit, for that wonderful opening talk. I would request Dr. Hetal to take it forward, please.
Thank you, Amit, for making my job easier. First of all, I would like to thank ISA Borivali, Dr. Shilpa Madam, Yogen Bhatt sir, Dr. Rao sir, Dr. Tendulkar sir for inviting me for this wonderful webinar. And it is very heartening to see 200 participants in this webinar. So I would like to let ISA Borivali for this successful webinar. So I'm going to speak about the basics of LOR blocks in abdominal surgery first. Then I will move to other part that is how to give those blocks. So first we will see the basics of LOR blocks. Many of us are freelancer and question comes to our mind is I don't have ultrasound machine, I don't have PNS, but I want to provide pain relief to my patient. So how can I do it? Just a minute. Okay. Question comes to our mind is how can I do that? But answer is there, LOR blocks. So if you know how to give landmark guided blocks or blocks with LOR technique, you can give any of this block like lateral tab block or subcostal tab block or rectus sheath block with LOR technique. But you need to understand some basics of LOR blocks before moving to how to give it. So why LOR blocks? Answer is ABCD. That is anybody can do it. So it's an era of facial pain blocks, as Amit said. There are a number of blocks emerging every year. Every year you attend AORA, you will find there are many blocks, newer blocks, facial pain blocks, and you can provide analgesia to your patient to facial block, pain blocks without fear of epidural hematoma or any other complication, because facial pain blocks are very safe, they are very easy to give, and they provide excellent analgesia. If you look at the facial plane blocks, they are with some distinct blocks because we are depositing the drug in facial plane that is between two muscles. So when you pierce that plane, there is some distinct pops, just like epidural when we are giving epidural. So if you understand how to perceive that pops, you can easily give block with high success rate. So which blocks we can give with LOR technique? We can give thoracic periorbital, we can give TAB, we can give rectus sheath block, we can give erectospiny blocks, and all the chest wall blocks can be given with LOR technique. What we need local anesthetic drug, we need syringe, and we need just one hypodermic needle or spinal needle. That is enough to provide any facial pain block. We will learn how to give it. So first, we need to learn how to blunt the needle tip, because when we want to feel the pop of the fascia, we need a blunt tip needle, because if you use sharp tip needle, it will easily pierce the fascia and you will not feel that pop or bounce. So you need to know how to blunt the needle tip, because we are using either hypodermic needle or we are using a spinal needle to give this block. We need to understand the concept of cushion effect. We will learn in further slide what is cushion effect, and we need to learn about feeling of bounce and pops. So we can, for giving the block, we can use Tuhi needle, we can use pencil point sharp spinal needle, or we can use block needles. But of course, if you don't have anything, you can use hypodermic needle or spinal needle in obese patients. So how to blunt the needle tip? So simple and easy technique is you can use 2 needle. If you want to use 21 gauge needle to give the block, use another 18 gauge needle, rub inside the bevel of the needle with other needle, and you will find how to make the needle tip blunt. This is simplest technique how with that you can blunt the needle tip. You rub it two to 3 times and your needle tip will be blunt, and you can use it to fill the pops. Second technique is this is the sterile bowl with local anesthetic drug, and I'll hit the bowl with. So here you can say I'm hitting the bowl with, and you. So once you blunt the needle tip, it gives a shape of parrot tip. When you insert such needle, you will have a resistance and you can feel the pop. Next important concept is concept of cushion effect. It was nicely described in the review article, The Loss of Resistant Nerve Block by Dr. Shiv Kumar Singh and team. So what is the cushion effect? When you insert the needle, here you can see the syringe is on the skin. So when your needle tip is blunt and you try to pierce the needle, it will create a pressure. And when it presses, the subcutaneous tissue will get compressed, and at the same time, muscle will have some compression. So when you forcibly pierce the skin with your blunted needle tip, sometimes what happens, you pierce one layer of the fascia without feeling the pop. So when you pierce the skin, there will be a resistance. There will be sudden giveaway, and you will pierce the first layer of the fascia. So you will not feel the proper pop, and you will end up giving it the drug in the wrong plane. So how to prevent this effect, cushion effect? So you can insert the needle perpendicular to the parallel to the skin. So initially you insert the needle parallel to the skin, then make it perpendicular to the skin. Once you are inside the skin, then fill the pop. So this is parallel to the skin. Then I make it once I am inside the skin, I will make it perpendicular to the skin. Then I will advance the needle. I will hit the first facial layer, and I will feel the bounce and pop of the needle, and I will try to inject the drug. So once I feel the bounce and pop, I will advance the tip to feel the pop of second layer. Or else, if you want to deposit the drug, you can deposit the drug there. So this is how you can prevent the cushion effect. If you don't know how to prevent the cushion effect, you will end up giving the drug in the wrong place. Another method to prevent cushion effect, you can make an incision inside the. You can make incision either with 18 gauge needle, then insert the needle through that puncture, or you can make an incision with a stab knife and then insert the needle. You can use needle through needle technique with a pencil point needle, or you can, once you insert the needle, withdraw to the skin, then re-advance the needle at little different angle and feel the pops of the facial layer. We will see in the video how to do it. So filling of the bounce and the pop. Suppose this is the tap block. Here you can see this is the tap block. This is external oblique, internal oblique, and tap. This is transverse abdominis. So our target area is this. So how to fill the pop, bounce and the pops? So once I advance the So here you can see I'm on the external oblique. I will bounce the needle. Then there will be sudden pop. Then I will advance, again bounce. I will do bounce and pop. Once I am inside the facial layer, I'll start injecting a drug, and it will spread in the right plane between internal oblique and transverse abdominis fascia. So important tip is you have to bounce your needle on the facial layer. Then only you should feel the pop. You should not go forcibly inside the facial layer. If you feel this bounce, you can easily feel the pops, and you can inject the drug in right plane. You will say that I am giving tap block for my CS patient, I am giving tap block for my other surgery, and it is failing. Why my block is failing? Why it is so? first important thing is to learn the anatomy. As Amit said, we need to understand the anatomy. If we don't know about the dermatome, myotome, and osteotome of the particular area, you will end up giving wrong block at wrong place. Suppose incision is above umbilicus, and if we give lateral tap block, it is of no use. Patient will not have any pain relief. So we need to understand which block should be given in which surgery. Then only we will give successful block. Another important point is, as we have discussed, we fail to understand the cushion effect. If we don't know about the concept of cushion effect, we will end up giving at the wrong plane. Third and important point is, as Amit has said, it is part of multimodal analgesia. This tap block or rectus strip block, it doesn't cover visceral pain, and it is part of multimodal analgesia. We have to give other analgesic like NSAIDs or paracetamol or some small dose of opioid to cover the visceral pain to complete the analgesia. It will take care of 70 to 80% of the somatic pain. It will cover the pain up to the peritoneum, but if you go inside the peritoneum, visceral pain, it will not cover. So we have to provide multimodal analgesia to provide complete analgesia to the patient. And don't forget, they are, as I said, they are part of multimodal analgesia. These are high volume blocks. So suppose if you want to give tap block and rectus strip block for midline laparotomy, we have to give bilateral tap block, bilateral rectus strip block. We have to deposit 20 ml for tap block on each side. We have to deposit 15 ml for rectus strip on each side. That makes 70 ml. So we have to calculate the toxic dose. We have to dilute the drug. We can reduce the concentration because these are for analgesia only, but we require enough volume to provide complete analgesia. So we should calculate the toxic doses, and then only we should do it. So if you understand the concept, success, it is very good. These are my own data. You can see the red is with landmark guided technique. Even I do have ultrasound machine inside my operation theater. 35% of my blocks are with LOR technique. I keep doing it because I want to keep this technique alive, and I want to keep this technique alive for my freelancing friends, because I have done freelancing practice. I know.
I'm muting everyone. Sorry to interrupt. I'm muting everyone again.
So if you look at this data, you can see 36% of the patients, my patients are with LOR technique. And I want my freelancing friend, because I have done freelancing practice, I can understand they don't have ultrasound machine. Many times they don't have PNS machine also, and they want to provide analgesia to their patient. So if I practice LOR technique, I can teach to my friends, and that's why I keep doing it. So you can easily do all this block with LOR technique, and we will see how to do it. This is my website, and this is my YouTube channel where I have uploaded all these videos, so you can see it whenever you want to see. So my second presentation will be on abdominal wall blocks. Can you see my slide?
Yes, Dr.
Yes.
Yeah. So now we will talk how to give all these abdominal wall blocks, tap block and rectus strip block with LOR technique. So if you look at the 20th century, we were giving either epidural or continuous spinal for all our blocks. So it was era of epidural. So for abdominal surgery, we were giving putting epidural catheter. But as we have evolved, many of our patients are coming with antiplatelet drugs or anticoagulants, and we cannot give epidural in such patient. And sometimes it is difficult to wait for 7 days for going for surgery. So in such cases, these blocks are like boon. So in 21st century is the century of facial plane blocks, and it started with tap block that was in triangle of Petit. Here you can see this is triangle of Petit. So tap block was described first in the triangle of Petit, and then it evolved with various technique. We will see how to give it. So anatomy is explained by Amit, but I'll quickly revise it. As Amit has said, upper part of the abdomen, below the in the subcostal area, it is supplied by T7, T8, and T9. So for that, we require a subcostal tap block. T10, 11, and 12 are in the mid-axillary line. So for that, we require lateral tap block. And if we go in the area just above the iliac crest, you will go for ilioinguinal iliohypogastric nerve block in tap plane, and with that you can provide analgesia for your hernia surgery or LSCS surgery. So if we look at the anatomy quickly, this is external oblique muscle. If I remove it, you can see rectus muscle and internal oblique muscle, and if I remove it, you will see these are the nerves that they are lateral cutaneous branches of T10, 11, and 12. So all these nerves travel in the tap plane, and if you deposit the drug here, you will block these nerves and you can provide the analgesia to lateral abdominal wall. And if you look at this rectus muscle, these are the anterior cutaneous branches, and if you deposit the drug below the rectus muscle and above the posterior rectus sheath, you can provide analgesia to midline of the abdomen. So anatomy is important to understand. So important anatomical point, I will revise it. Anterolateral abdominal wall has three muscles, that is external oblique, internal oblique, and transverse abdominis. T10 to T12 enter tap plane in the mid-axillary line. So if you deposit the drug there in the mid-axillary line, that is your lateral tap block. T6 to T9 enter in the tap plane medial to the anterior axillary line in the subcostal area and in the rectus sheath. So if you deposit the drug there as described by Amit with subcostal tap block, it will cover the subcostal area. T6 enter just lateral to the linea alba, and ilioinguinal iliohypogastric now get innervation from T12 and L1 and sometimes by L2 and L3 also. So if you enter tap plane near anterior 1/3 of the iliac crest, you can block ilioinguinal iliohypogastric now also. So classical aerol trap block was described initially in the triangle of Petit. It is from anteriorly by external oblique and posteriorly by the latissimus dorsi. And if you fill the two pop and deposit the drug, this is something like QL1 block. So initially when they started classical tap block, they found that there was some visceral analgesia component because of spread of the drug to the thoracic paravertebral block, just like QL. But if you look at current practice, we are depositing the drug in the mid-axillary line here. So if you deposit the drug there, there are less chances that drug will go up to the thoracic paravertebral space, and that's why there is no visceral analgesia. So this part is covered by Amit, so I will not repeat it. So for upper abdominal, it is used for upper abdominal surgeries like major upper abdominal surgery, laparoscopic cholecystectomy, bariatric surgery. In lower abdominal surgery, all gynec surgeries, colorectal surgery, appendectomy, hernias, plastic reconstructive surgery, renal transplant, donor nephrectomy. For all this surgery, you can use tap block. In obstetric surgery, it is used widely. Tap block for LSCS, you can use it with GA, you can use with spinal. After giving spinal, you can give tap block. And ilioinguinal iliohypogastric nerve block, I will say it is better for LSCS to provide analgesia. We have seen this video. So for tap block, I will show the video how to give it. We will give it with ultrasound first, then we will confirm with, with LR technique first. Here you can see this is the patient of LSCS. The surgery was done with spinal. Now I am palpating the anterior superior spine. I will go 5 centimeter cranial and 5 centimeter lateral. So that is the entry point for tap block, that is ilioinguinal iliohypogastric nerve block. So once I have blunted the needle tip, I am inserting the needle through the skin. I am feeling the resistance because it is blunted needle. Here you can see I am feeling a lot of resistance. Once I am inside the skin, I have withdrawn back, and now I am feeling the pop of the external oblique fascia. First, I will feel the pop bounce and then pop of the external oblique fascia. Once I get it, I will advance the needle. Here you can see I have advanced. Now I am feeling bounce and pop of the internal oblique fascia. Once I am feel the pop, I will start injecting the drug. After careful aspiration, that is important, I'll inject 5 ml of LA. Again, I will aspirate and inject. Always aspirate before injection. That is very important for any block. So after 10 ml of LA, we will see the backflow of the drug. If I'm getting good backflow, that means I'm in the right plane. If I'm going intramuscular, there won't be good backflow. Here, if you put the PNS, you will see the muscle contraction of the abdomen because you will find your ilioinguinal iliohypogastric nerve in this plane. So after filling the pop, if you start PNS machine, you will get the contraction of the anterior abdominal wall muscle, and you can confirm with PNS also. So here you can see I've injected 20 ml of LA. This is external oblique. This is internal oblique. This is transverse abdominis, and you can see the drug has spread nicely between internal oblique and transverse abdominis muscle. I will again repeat the technique. You have to palpate the anterior superior spine. Once you palpate the anterior superior spine, go 5 centimeter cranial and 5 centimeter lateral. That is just above the iliac crest. Fill the 2 pop, and you will inject the drug in the tap plane. That is for ilioinguinal iliohypogastric nerve. If you want to give a tap block, lateral tap block, then you have to draw a line you have to draw the iliac crest, you have to draw the costal margin, you have to draw the mid-axillary line, and at the midpoint you insert the needle, fill the 2 pop, and you will in the tap plane. For subcostal tap block, here you can see how to give it. So for subcostal tap block, here you can see this is the anterior axillary line. I'll draw on the costal margin. So I'll go 3 to 4 centimeter medial to the anterior axillary line. So here I will find the 3 muscle layer, that is external oblique, internal oblique, and transverse abdominis muscle. So I'll give this, and I'll supplement it with rectus sheath block to complete my subcostal tap block. So you will see this is the anterior axillary line, this is subcostal, this is costal margin, this is subcostal area, and this is the point where I will insert the needle. Here you can see I am going through the skin and I am filling the pop of the external oblique. You can see, yeah, first pop, then bounce, and again second pop. Once I fill the second pop, I'll start injecting the drug. I'll inject again 15 to 20 ml of LA here for subcostal incision. You can use this block where a surgeon is planning the incision above the umbilicus in the subcostal area. So once I inject the drug, I will confirm with ultrasound whether it has spreaded in the right plane or not. So I'm putting my ultrasound probe to confirm my injection. So I'm there. I'll check whether drug has spread inside the proper plane or not. So I'm confirming it with ultrasound. You can see this is the linea semilunaris, and I'm going laterally. And here you can see this is external oblique, internal oblique, and transverse abdominis muscle, and the drug has spread nicely in between the 2 muscles. So here you can see you can give this block with LOR technique. So you can give lateral top block, you can give ilioinguinal iliohypogastric nerve block, you can give subcostal tap block. How to give rectus sheath block? Now we will see how to give it. It is for upper midline incision and upper pyramidal incision. So if you look at the anatomy, rectus sheath, there are 2 layers. There is 1 layer above the rectus muscle, that is anterior rectus sheath, and below the rectus muscle, that is posterior rectus sheath. So our aim is to deposit the drug below the muscle and above the posterior rectus sheath. So again, we will fill the bounce of the anterior rectus sheath. We will fill the pop and advance the needle. Once I feel the second resistance, second bounce, I'll inject the drug here. So for rectus sheath, there is only 1 pop. Bounce, bounce, pop, you advance the needle. When you find the second resistance or second pop, second bounce, you have to inject the drug because you want to deposit the drug above the posterior rectus sheath and below the rectus muscle. So here you have to deposit the drug after 1 pop and at the second resistance. So we will see, this is the video by my fellow. He did a 1 week fellowship at our center, and he sent this video to me And he did this surgery in the patient, and it was under regional anesthesia only. This was an incisional hernia, and see how he is giving the block. He has made a puncture in the skin. Here you can see he is using. Patient is awake. Now he is feeling this was a high risk patient, so he wanted to do under block only. So he did it with rector sheath and tap block. So he is feeling the bounce of the anti-rector sheath. Once he pierces the rector sheath, he will inject the drug in the electrodes of 5 ml. So now he is at the second resistance and he will start injecting the drug. He has taken 10 ml of LA. He is aspirating and injecting. So you can see after 5 ml of injection, he is checking the backflow, and drug is coming nicely in the backflow. So you can see the drug coming back. So you are in the right lane. So if you give bilaterally with 20 ml of LA, you can give both side rector sheath block. So you can do the surgery with this technique also. As Amit said, we need to understand the anatomy. So suppose if we are giving the block for LSCS, incision is facial. So in such cases, bilateral lower tap or ilioinguinal iliohypogastric nerve block is the nerve block of choice. So you have to give bilateral block. You have to give 20 ml of oil on both the side. So what I do is I take 0.5% ropivacaine, I dilute it up to 40 ml, 20 ml of ropivacaine, 20 ml of saline. So I make it 40 ml and I inject 20 ml on each side. Suppose it is inguinal hernia, then again you have to give ilioinguinal iliohypogastric nerve block. For that, you have to palpate anterior spine, go 5 cm cranial, 5 cm lateral, inject 20 ml of LA, and you will have good effect. But for inguinal hernia, you need to block a genital branch of genital femoral nerve also. So once surgeon is on the sec, you can ask him to inject 3-4 ml of xylocaine inside the sec, and it will take care of genital branch of genitofemoral nerve. For midline left, I said we have to go for bilateral rector sheath block and tap block. So I take 0.75% of ropivacaine, 20 ml. I dilute it up to 70. So 20 ml of ropivacaine, 50 ml of saline. So it makes 70 ml of LA. So I inject 20 ml of LA for tap block and 15 ml of LA each for rector sheath block. Paramedian incision, you require only one side, right or left side of tap and rector sheath block. Subcostal incision is, I said, you should go for subcostal tap block. There is safety concern like needle trauma, maldistribution of the drug, and last. So when you are giving this block with landmark guided technique, we are worried about liver trauma or any visceral trauma. But if you follow the technique properly, you follow the you understand the importance of cushion effect and you follow the guideline, there are less chances. Maldistribution of the drug, that is also important. If you inject the drug intramuscularly, high volume of drug can lead to local anesthetic systemic toxicity because drug absorption is faster when it is intramuscular. So to conclude my talk, choose your block wisely according to the type of surgery. Tap block is part of MMA. It doesn't cover the visceral pain. They are high volume blocks, so be careful in selective volume and concentration of drug. There is a newer block. I haven't given it with LOR technique, but we can give it. So how to give it, I'll show. That is external oblique intercostal block. This is used for upper abdominal surgery. There are studies where they have observed that with subcostal tap block and rector sheath block, there is not adequate coverage of the above umbilical incision. So what they found is if you deposit the drug below the external oblique muscle and above the rib at the sixth or seventh rib, you can easily block all these nerves and you can provide excellent analgesia. So here with ultrasound guided technique, what they are doing, they are looking at sixth or seventh rib in the anterior axillary line, and they are depositing 20 ml of alloy. Here you can see this is sixth rib and seventh rib, and they are depositing the drug below the external oblique muscle and above the rib to block these lateral cutaneous branches and anterior cutaneous branches of the intercostal nerve. So how you can give it with LOR technique? You simply draw the anterior axillary line, You palpate the 6th and 7th rib, you hit the rib and deposit the drug, and it will below the external oblique muscle. If you provide adequate volume, it will block the nerves. So I haven't done with a landmark guided technique. I will definitely make a video with this technique. But I was reading about all these blocks, and I thought that even this block can be given with a landmark guided technique, and you can have good effect. So about abdominal wall blocks, thank you very much.
Thank you, Dr. Hetal. That was brilliant. I think when all of us were doing also ultrasound guided blocks, I'll keep a watch out of the cushion effect and the pops when I'm doing it, and I'll let you know how that works. So I'll request Amit to start his talk about the anatomy of the chest wall blocks, please. Amit, over to you.
Yeah, surely. Thank you. Yeah. So after that wonderful description by Dr. Hetal, I'll be moving ahead. Anatomy of chest wall blocks. You can...
So I'm muting everyone. Only the speaker can unmute.
Yeah, so coming to anterior and the anatomy of chest wall block, I am again trying to cover with whatever are the simple anatomical landmarks which we must know. And, yeah, so could you please mute? Yeah, thank you. So my outline, as I have showed it for the abdominal wall blocks, again, I'll be covering the gross anatomy where exactly the block is being performed. Then I'll be covering the sono anatomy, which we need to know what all muscles, nerves are there. I'll try to correlate it with a schematic anatomy diagram and the nerves getting blocked.
Everybody please mute except Amit. We can't, he gets disturbed, please. Thank you.
Ankita, please mute everyone.
All right, so we already know the osteotome, myotome, dermatome, and now we are dealing with a little tricky area when it comes to chest wall blocks, because now we have some innervations of brachial plexus elements as well. This is over and above the thoracic dermatomes. So we need to know here the course of how the spinal nerve roots, the dorsal rami, the ventral rami. So I'm just highlighting what is the course of a intercostal nerve. So intercostal nerve pierces the posterior intercostal membrane 3 centimeters lateral to the intervertebral foramen, and then it enters the subcostal groove of the rib. And here the nerve travels between parietal pleura and the intercostal membrane. So I'm just talking about the initial first 3 centimeters where it has entered the groove. And here the nerve is in very close proximity of parietal pleura. And so when we are talking about, the intercostal blocks, we do not do it very, very close to that area because we can damage pleura here. So where we do these intercostal nerve blocks is as the intercostal nerve progresses laterally, that usually at the lateral to the angle of rib, the nerve enters the space between the innermost intercostal and the internal intercostal. So internal intercostal muscle here, innermost and the internal. These are in between these two, the nerve tends to lie. And therefore it is little bit away from the pleura. And there it continues to remain there along with the intercostal arteries and nerve. So I'll just show you where exactly it is. So this is what is the rib. And then we have an external intercostal muscle here. And then we have internal intercostal and the innermost intercostal. And between them are the intercostal nerves and vessels. So usually at the angle where the rib tends to move it has an angle laterally, so which is quite far off distance from the midline. So it is so when we slowly the nerve has formed and it has moved through the groove, and now it is at the angle of the rib. So in that push on the back where we would like to do this intercostal nerve block, we just go beneath, and then most of us have done the intercostal nerve blocks. It is a little labor intensive because we have to do it and block it at multiple levels. But I'm sure still it is a very useful and a fantastic block, and as less as 1.5 or 3 ml is good enough dosage. Now coming to PEX block, which is again discovered by Rafael Blanco, and PEX block are the pectoral block, PEX 1, 2 we know, and here we are trying to address mainly the brachial plexus component and all the, now they use a terminology called pectoral plexus of nerves. So what is, now the nomenclature has changed. The pectoral block is now named as interpectoral and pectoserratus. So where exactly, so it's a whole block with 2 injections. One, LA is deposited deep to pectoralis major. It is called interpectoral plane. It is between major and minor. And then the LA is deposited deep to pectoralis minor. So it is between pectoralis minor and serratus anterior plane. So if you are doing a pectoral block, you have 2 injections. This is the first one and the second one. So what all nerves are blocked? So lateral branches of intercostal nerves from T3 to T6, medial and lateral pectoral nerves, which are branches of brachial plexus. It may sometimes block T2. So this block, when we are doing a breast block for surgical anesthesia, we use intercostal nerve block by using either PEX or SAP, because we do not wish to do a thoracic paravertebral at T1 and T2 level where drug may ascend up. So we can use this anatomical knowledge so for a classical surgical anesthesia for a breast surgery, probably T2, 4, 5, 2 or 3 injections, 4, 6, and maybe 3 or 2. But this addition will definitely cover the axilla and the upper aspect of arm and all that area, and we can extrapolate this advantage. So it may block intercostobrachial when we are using volume, and it may also block the nerve to serratus anterior, which is the long thoracic nerve. So you need to see what all the nerves here are. So that's first is the pectoral nerve, the medial and lateral pectoral, which lies between the pectoral muscles, medial, the pectoralis major and pectoralis minor. So this is very well nicely addressed. You can even use PNS, and there is a definite vascular landmark also. We see the pectoral branch of thoracoacromial artery, and just adjoining that is the pectoral nerves. Then we have this serratus anterior and latissimus. So nerve to serratus anterior and nerve to latissimus dorsi are also, we can address, but as far as PEX is considered, it will cover mainly nerve to serratus anterior. Nerve to latissimus dorsi is probably covered better with SAP block. So we'll come to it a little later. So PEX block has 2 injections, and previously it was known as PEX 2 block, where first injection is the interpectoral, which is PEX 1, or it is called as the first injection of PEX 2. And second injection is the pectoserratus, which is the second injection of PEX 2. So basically 2 injections we have to deposit. And I'm looking at the anatomy somewhere just below the clavicle, where pectoralis major, the chest. And what actually I see is this, a major muscle, a minor muscle, and below is the serratus anterior. So the block here is just the sliding for the second injection over the third and fourth rib. I can easily deposit the drug between pectoralis minor and serratus anterior. So once I complete the block over say fourth rib, the picture and anatomical picture is we have a major muscle and a minor muscle. In between these two, I've deposited the drug. In serratus anterior and a minor, this is the second injection. Now with the volume and the drug, definitely Hetal will show you. And I have done this block with landmark, and sometimes in elderly patient, we may miss with the cushion effect. But of course, Hetal was not there when I did it. Probably after learning properly this technique of cushion effect, probably in those challenging cases also we can perform these. So once or twice this has happened to me that with pops and clicks I have overdone it, and I have pierced actually the pectoralis minor muscle also, and I have actually caused an infraclavicular brachial plexus block. So the block, this was once or twice it has happened. So we have to be careful while performing this block. Of course, Hetal will guide you with final tips. What about SAP block? SAP block definitely for anterior chest wall analgesia, just like PEX. And the advantage here with SAP block is LA is deposited either superficial or deep to serratus anterior muscle over the rib. So here bone is our friend, and just hitting the bone and aspirate, inject, and you can have a very good dermatomal cover from T to 6. Again, we have to do this block at the mid-axillary line or little bit on the posterior aspect, because we know that the lateral cutaneous branch of intercostal nerve, they are branching out from there, and we do not wish to miss the lateral cutaneous branch. So preferably this block to be done at mid-axillary line. We can hit the rib at say T4 or T5 level and just deposit the local anesthetic very easily. So intercostobrachial nerve may be blocked. It is the T2 branch, and it pierces the anterior muscle to provide anterior cutaneous innervation to axilla, the upper half of medial and posterior aspect of arm. So even with proximal humerus, this is sometimes the superficial infiltration is done, but here this is an advantage. So what is the analgesia distribution for SAP? Now, when I am comparing PEX and SAP, so PEX block and SAP block. So here there is advantage of thoracodorsal nerve. So nerve to latissimus dorsi is also getting blocked, and we have a little better coverage from T3 to T9. Now, is it better than local infiltration? These PEX and SAP, definitely they are better, and especially with breast aesthetic surgeries where there are breast implants. Sometimes these implants are put inserted below or in the pocket around the muscle, and therefore as the implants are getting inflated, there is a lot of pain to that muscle soreness can happen, and local infiltration will not cover that. So you need a muscle paralyzing block, and we know that pectoral nerve is a motor nerve, and it has also got a sensory distribution. So with PEX block, we definitely cover the pectoral nerve, and therefore the quality of analgesia is better. Now, as far as SAP is considered, we are predominantly using it for as an addition for breast analgesia along with PEX1, and we are also using for all those lateral and anterolateral fracture rib. So yes, so where we deposit the drug, you can see near around nipple line at 4th or 5th rib, and you see this thoracodorsal artery. In pectoral block in PEX1, we see the pectoral branch of thoracoacromial artery. Here is a thoracodorsal artery. So there are some vascular landmark, and while doing landmark block, we have to be careful not to puncture these vessels. So aspirate, inject very slowly. And what we see is the latissimus dorsi, we see serratus anterior, and we see ribs. So if we are planning to do a superficial block, then we deposit the drug superficial to serratus anterior, and that's the superficial SAP. But deep is easier with landmark because we are just hitting the rib, probably in the mid or mid axillary line or just around posterior axillary line, and we deposit the drug, and there is a very nice spread. So even with chronic pain syndrome, chronic post-thoracotomy pain syndrome, or there is cicatrization or a bad scar tissue, even in those cases as well, where you cannot feel good pops and clicks, rib is our friend, and we can just hit the rib and deposit the drug, and we can have a very good drug spread. Once or twice, as my surgeons are doing PEX block, they have caused pneumothorax. So you have to be careful while putting the needle, and you should, as we practice and as we take good precaution, we can definitely avoid that. Now, ESP block is the block, the new block, and which has been used just like TAP. So it is said that TAP and ESP are the block for anesthetists, whereas quadratus lumborum block probably is a little complicated block. Those who are genuinely interested in regional and those who have facilities with ultrasound can definitely try that. But in at least each and every anesthetist in present era must know TAP and ESP. So all the abdominal blocks which Hetal has already shown. So few things about erector spinae, and it is blocking the intercostal nerves from T1 to T12, because erector spinae actually starts from right from the right from the cranium and going up to the sacrum. So anywhere below the erector spinae muscle, if we deposit drug, whether it is cervical, thoracic, lumbar, we can definitely have some dent on analgesia, and it will reduce the VAS score. And in combination with multimodal analgesia, you can have a better strategy of pain management. They have shown that it is mainly a dorsal rami block, and it rarely blocks ventral rami. In my personal experience, in some patients, it has worked wonderfully well. Most of the time, I would say that it has worked well, especially when the patient is elderly with low mass of muscles. It has worked even wonderfully well to an extent that there was an epidural spread and hypotension. But those hefty guys, in some patient, probably it has not worked well. Probably the plane has not opened very well, or the diffusion as drug has not happened well. And so there are some caveats, and people think, so there are a group of people who some of are believers of ESP, some are not believers of ESP. I think this block definitely has a place in present day regional anesthesia, because it can be done in a very simple way, where we palpate for the transverse process just 3 centimeter lateral to the spinous process, and we can hit the transverse process with the help of a blunt tip needle, and we can deposit the drug. So the important factor which differentiates it from a paravertebral block is has no sympathetic chain blocking action. Whether it goes to paravertebral space and epidural space, the results are inconsistent. So we cannot be 100% sure that its action is through paravertebral and epidural action. So it is still a topic of hot debate, even with present day journals of RAPM. So how we do it? So roughly, it is easy to palpate the spinous process, and 3 centimeter lateral. When we pass the needle, we hit the transverse process. And here again, the bone is our friend. And we cross the trapezius, the rhomboidus, and the erector spinae, and the drug is deposited over the transverse process. Yeah, Ankita, you can mute.
Ankita, please mute everyone.
Yeah. So you can see the drug.
I'm again muting everyone. I'm again sorry to interrupt. Again muting everyone, and please only the speaker.
I think you can remove the participant if they are making continuously noise.
All right, ma'am. As you have given the permission, ma'am, I will do it.
Yeah, please
do it. Please remove.
Yeah. Please
okay, ma'am. Okay, ma'am. Okay, ma'am.
Yeah, thanks.
All right. So erector spinae, we can very well appreciate, and a drug is deposited just below the erector spinae muscle. In elderly patients, you can see the drug lifting whole muscle. With a young patient with good muscle mass, sometimes it may be challenging to open up this interfacial plane. With ultrasound, you can see the spread of drug, whether it has happened or not. But I have done this block with landmark as well, and it has worked well in most of the situation. We got confidence with this block with bariatric patients, in this subset of patient, even the ultrasound block is even challenging. So just 3 centimeter lateral and hitting the transverse process, and it's a very good block which we can do. Thoracic paravertebral block, as Hetal and me decided that we can cover this block also. So here we are not going at the tip of transverse process, but just medial to it. It is 2.5 centimeter from the spinous process. And here the advantage is it is not only blocking the thoracic spinal nerve, but also the component of sympathetic trunk. The cephaloid limit of thoracic paravertebral space is not well defined, whereas the chordoid limit is at the origin of psoas muscle, that is at L1. And it consistently blocks the ventral rami, the dorsal rami, the sympathetic trunk. We were discussing this topic about the correlation of anatomy and block action for ESP, for quadratus lumborum, and what Rafael Blanco has to say that anatomy is giving us the partial explanation. This was his talk in last AORA. And anatomy may not tell us each and every mechanism. Probably the mechanism is molecular. Sometimes we think that the fascias are the dead tissue, but there are now reports where there can be sympathetic neuronal elements, there can be Mephinian corpuscles, the Raffinis nerve ending, and there are some, the systemic absorption. So the mechanism of action can be something else. So we should not always think that some nerve is blocked or it is indirect paravertebral action and that is why block is acting. We are not sure exactly how the blocks are acting. So there are multiple hypotheses and this is still evolving. Of course, this block was just, all these interfacial plane blocks are still 10 or 15-year-old at the most. So, but when we talk about paravertebral, it is a very convincing block. Block was done in 1950 and robust evidence that it can be done very well. Most of the anesthetists, what I have seen in my practice is they probably are not afraid of cardiac arrest the way they are afraid of pneumothorax. So that is why probably everyone is so scared of paravertebral because they think that they will cause pneumonia and then ICD, and how can we convince the surgeon? Of course, this fear is always there, but there are some advantages with this block. And when we use landmark method with loss of resistance, epidural to he needle, we can use it. Some of the freelancing anesthetists have shown its application and they are using it for PCNL surgeries, multi-level. Even Harshal is using it for VATS. I am also using it for breast and VAS surgeries. So it has now, it is revisited. This block is being practiced and used. So when we look at the transverse anatomy at the paravertebral space, what we see is I can show you the schematic anatomy. And the superior costotransverse ligament, the paravertebral space, and here both the dorsal and ventral rami are being bathed. And if we deposit local anesthetic, it will not only block this, but these two dorsal and ventral rami, but also the sympathetic chain. And therefore, it has a very good component of visceral analgesia. And this is how in the schematic diagram you can see. And with landmark, I have done this block on a very regular basis, and the loss of resistance is not very classical as that of a epidural, but definitely you get loss of resistance to saline or air, whichever way you practice, and it is a very convincing block and can be done in selective group of patients. When it is sagittal, we see we place the probe in the parasagittal area, and we see almost all these the structures where we have the we have to move little bit more medially to see and appreciate the transverse process, the ribs, and how we enter the paravertebral space and we deposit the drug. Now, in my routine practice, I either use the transverse technique when I'm doing it with ultrasound. So most of the time the image is like this and the nerve is coming from lateral to medial direction. Or when I'm using it with landmark, then of course it is 2.5 centimeter. We just mark it and go straight. That Hetal probably will be showing you in a short while. A little bit about the pectointerfacial plane block or a transversus thoracis plane block. These are the parasternal blocks. And sometimes even the local infiltration in the pectoral muscles here will definitely cover. If you have ultrasound, then you can do a pectointerfacial plane block or go a little bit closer to the vessel and deposit and try to block the terminal branches, which are the anterior cutaneous branches, which are covering the sternum. And people have even placed the catheter here as well. A word of caution, we should not be damaging the thoracic artery, the internal thoracic artery, because it is useful for CABG and graft. So this lima, and all that vascular challenges should not happen. And therefore, most of the time, transversus thoracic plane block is not done, and people just try to limit their needle insertion into the pectoral muscle, and they do a pectointerfacial plane block. And this is how the sonoanatomy is seen. Do not go much closer. It may affect the vessel, or you may be very close to pleura. So even if you just do a little bit of infiltration in the muscle here, lower down, it will, by diffusion, the block acts well. So this block already being covered in the abdominal class, but probably this is similar to that of a SAP block where we have a rib, and Hetal has already mentioned. The importance of, I have done this block with ultrasound, and Hetal only has come up with this idea that it can be easily done with a landmark. And when we have done this, the indication was PTBD. And when they put that, all that Chiba needle and all that, lot of incision, and we cannot do, much of them have very high bilirubin. So we thought we can utilize this. Of course, again, the limitation is it is not covering the visceral component of pain relief. So we have to supplement some amount of multimodal or opioid. But open laparotomies, especially the open cholecystectomies, which will cover the area between T6 to T8. I think this block is very, very efficient. And here the drug is deposited over, LA is deposited near the 6th or 7th rib, and it is at the anterior axillary line, sometimes little medial to it, and you can already, the Hetal has shown. So this is how it is done. Block assessment, which I have already covered. No block is complete unless we have assisted, and it is good idea that we have some conviction. Now, when we follow these patients for our post-operative round, say if you have done a bilateral ESP, then initially you will see this much area. Then slowly on the documentation, we say that from T6 to L1, both sides. Then slowly it recedes to T9 to T12. Then sometimes after 48 hours, it may be at around only periumbilicus. Later, we may find no hypoesthesia, but still the analgesia continues. So the exact mechanism is still not known. Sometimes our erector spiny block or a single shot quadratus lumborum posterior QL block has lasted even more than 24 hours, even till discharge, second and third day. So we are really having interest in these patients, and we definitely utilize the opportunity to perform block in these patients. Thank you very much. Over to Hetal and Harshal. Thank you.
Yeah, Amit, thanks very much. I would request Dr. Hetal to kindly let us know about the block techniques in terms of chest wall blocks, please. Thank you.
Thank you, Harshal. Excellent presentation by Amit. So I will talk about first about thoracic paravertebral block. Second will be about erector spinae, and then we will talk about facial plane block of the chest wall. So as Amit has said, landmark guided tap block is an age-old technique. It was discovered in, I think, 1900, and it is like a gold standard technique. So it was started in 1905 by Hugo Salim, and initially it was practiced a lot, but then it disappeared from practice because of fear of pneumothorax, and it re-emerged in 1979. And after invention of ultrasound guided technique, it has become very much popular. But if you don't have ultrasound, don't get disheartened. It can be easily given with landmark guided technique, and I will say I prefer to give it with landmark guided technique rather than giving with ultrasound. Sometimes what I find is I insert the I take ultrasound. Sometimes it is narrow space in between two transverse process. It is sometimes difficult to insert the needle with ultrasound. I switch over to landmark guided technique, and then when I check the spread, most of the time I am in the right plane. So it is the technique of injecting LA in the vicinity of thoracic spinal nerve when it emerged from the intervertebral foramen. So we block the nerve at the emergence from the intervertebral foramen. So it is just like unilateral epidural anesthesia. It provides excellent somatic as well as visceral pain relief. It has got some, as Amit said, it blocks the sympathetic chain, so it has some hemodynamic changes, but as compared to epidural, it is quite less. So Amit has already described anatomy. This is a wedge-shaped space formed medially by the vertebral body and component of vertebral canal. It is medially formed by the ribs, posteriorly by the, if you look at the posterior part, it is formed by the superior costotransverse ligament, and anteriorly by the pleura. So basically, this is the paravertebral space. It is connected cranially to the upper spaces, caudally to the lower spaces. When you inject the drug spread medially towards the epidural space and laterally in the intercostal space. So there is a huge spread of the drug. But when you inject a single space, the drug may spread to 1 or 2 spaces, or sometimes to 4 to 5 spaces. So what is our aim is to hit the transverse process, redirect it caudally whenever possible to reduce the chance of pneumothorax. Then when you advance the needle, you will feel the pop of the superior costotransverse ligament. It comes at roughly 1 to 1.5 centimeter. Even if you don't find that pop, you can inject the drug at 1 to 1.5 centimeter beyond transverse process, and you will in the thoracic paravertebral space. And you can see drug is spreading inside the paravertebral space. It goes anteriorly to block the sympathetic chain. It goes in the intercostal space, and some of the drug goes in the epidural space also. So indications are thoracic surgery, abdominal surgery. You can use it for breast surgery. Even it is used for chronic pain like post-orthopedic neuralgia, post-thoracotomy, chronic pain, and fracture ribs. So for LOR technique, what you need to, suppose if you want to use it for breast surgery, then you palpate the C7 spinous process. It is the most prominent spinous process in the back. So you can easily palpate it. You palpate the C7 transverse process, then you can palpate T1, T2, T3, T4, T5. You go 2.5 centimeter lateral to it, insert the needle perpendicular to the skin, hit the rib. If you don't hit the rib up to 3 centimeters, either go cranially or caudally and try to find the transverse process of the vertebra. Once you find the transverse process, you withdraw the needle up to the skin, redirect it caudally, go 1 to 1.5 centimeter beyond the transverse process. And if you feel the pop, you can inject the drug. Even if you don't feel the pop, you can inject the drug. So another important point is when you palpate the, suppose this is T1, Then if you look at the spinous process, it is lower down. So in the line of the T1, there will be transverse process of T2. So you have to calculate accordingly. As I said, you have to initially hit the transverse process, walk up the transverse process and inject the drug, and it will spread in the caudal as well as cranial direction. You have to look at the dermatome and accordingly choose the block. Suppose it is for breast surgery, you need to block T1 to T6. So in breast surgery, when I give LOR block, I inject at T2, T4 and T6 level. I inject 7 ml of drug at each level and it provides excellent pain relief. You can use this block to provide complete surgical anesthesia also. You cannot use other block for surgical anesthesia, but this block you can use it for surgical anesthesia also. See, so this is the LOR tab block. Here you can, this was for nephrectomy patient. Here you can see I'm inserting the needle, and at 3 centimeter, you can see I have hit the transverse process. Once I hit it, I am redirecting the needle caudally, and you will feel you can see the loss of resistance also. So here you can see this was a loss of resistance at 4 centimeter, and when I started injecting the drug, it is nicely spreading. This is the pleura, this is the superior costotransverse ligament, and drug is nicely spreading in the paravertebral space. So you can give this block very nicely with a landmark guided technique. There are certain complications like pneumothorax, but we can prevent it. We will see in further slide. Epidural and intrathecal, this is the spread after the paravertebral block. You can see it going medially towards the epidural space also. There are chances of bleeding, so you should avoid this block in patient on anticoagulant and antiplatelet drug. If you don't take proper aseptic precaution, there are chances of infection, and it is a vascular area. So if you always aspirate before inject to avoid the chances of LA toxicity. Certain contraindication, as I said, like absolute contraindication is local infection, sepsis, patient refusal, local anesthetic allergy and toxicity, and tumor in the paravertebral space. And some relative contraindication like sternotomy, midline laparotomy, severe respiratory disease, ipsilateral diaphragmatic paralysis, and thoracic spine deformity. Some clinical pulse are always do marking with marker pain. This is important because if you don't do marking, you will end up giving it wrong place. Use needle with depth marking because you want to see where you hit the transverse process. So suppose if you hit at 4 centimeter, you should go maximum up to 5 centimeters. So always use needle with depth marking. Depth of transverse process varies at different thoracic level. It is most superficial at mid-thoracic level. If you go at T1 level, it is higher. If you go lower down, it is higher. But you should not advance needle 1.5 centimeter beyond the contact point with transverse process. So never go 1.5 centimeter beyond, otherwise you will puncture the pleura. Avoid directing the needle medially. If you go medially, there are chances that you will go inside the epidural space, and if you inject the drug there are chances of hypotension and other complications. Inject saline to expand the space for catheter. If you want to put a catheter, initially inject the saline because this is a compact space. It is not like epidural. You cannot insert catheter very easily. So always inject some saline before inserting the catheter. Very easy passage of the catheter suggests intrapleural catheter. So if you pierce the pleura, then your catheter will go inside very easily. Always attach syringe with needle while locating the space. This is very important tip because if you attach the syringe with the needle or with extension tubing, then even if you puncture the pleura while breathing, it will not suck the air. So even if you puncture the pleura, there won't be pneumothorax most of the times. But if it is open to air, there will be pneumothorax for sure. So always attach a syringe with needle or with extension tubing while locating the space. Use multiple injection technique wherever possible, especially when you are doing with LOR technique, because sometimes the drug doesn't spread in all segment you want to block. So if you use multiple injection technique, there will be good quality of block. This is the study where they compared the single to multiple injection, and they found that multiple injection technique is better as compared to single injection technique. There was a study, ongoing study, where they compared recurrence of breast malignancy and thoracic perivertebral block, and some of the results were telling that if you use opioid-sparing anesthesia technique, and if you don't use inhalation agent, there are less chances of recurrence, but there is not robust evidence. As I said, depth of transverse process varies at different level. At mid-thoracic level, it is minimum, but if you go at upper level or lower level, depth increases. So you have to be careful while locating the transverse process. This is the video of thoracic perivertebral block with PNS guided technique. I did it 2 days back only. I don't use PNS with PNS for thoracic perivertebral block because I like LOR technique, but this was just for demonstration purpose. As I said, this was for breast surgery. This is C7. Then I marked T1, T2, T3, and T4. This is 2.5 centimeter lateral to the spinous process. I'm inserting the needle and look for the response of the muscle. There will be contraction of intercostal muscle once I in the thoracic perivertebral space. I've hit the transverse process. I'm trying to walk up the transverse process and look for the response. So I'm walking up the transverse process caudally and look for it. You can see the loss of resistance. And there is some movement contraction on the muscles. So I'm doing some adjustment for a good muscle contraction. And now you can see, I will focus the camera at the chest wall, and you can see the contraction of the muscle with thoracic perivertebral block. You can see the contraction. Can you appreciate, Harshal? Yeah. So you can see the contraction of the muscle. Yeah. So this is how you can give thoracic perivertebral block with PNS guided technique. Also, Dr. Kala Ishwari is doing it regularly, but I prefer to give with landmark guided technique rather than giving with PNS guided technique. And after giving this block, I checked the spread, with ultrasound. And here you can see this is a nice drug spread inside the perivertebral space. So even with PNS guided technique, you can give this block easily. So this is all about thoracic perivertebral block. Now, next presentation is about landmark guided erector spiny block. Most of the things are covered by, just a minute. Sharing it again. I don't know why it is not synced.
We can see your slide, Hetal.
No, I'm looking for just a minute. I'll stop this thing and share it again.
We could see landmark guided ESP actually. That was the slide you wanted, no?
Yeah, that was the slide. I'm sharing it again, no issue. Can you see it now?
Yes.
So, next presentation is about landmark guided ESP. Most of the things are described by Amit. So as I said, I don't have ultrasound, I don't have IIT, still I want to give pain relief to my patient. So ESP was first introduced in 2016, so it is relatively new block. But if you look at the published literature till July 2021, there are 840 articles about ESB, and if you look up to July, up to 2023, you can see there are 1226 articles. So it is most discussed block these days. There are a lot of controversy, like whether it blocks dorsal root or whether it blocks ventral root. But it is practiced more and more and more. Many of us are practicing it regularly. So what is basic difference between thoracic paravertebral block and ESB? If you look at these are the muscle, erector spinae muscles and rhomboid trapezius. And if you walk up the transverse process and inject the drug, it will become your thoracic paravertebral block. But here in erector spinae block, we just hit the transverse process and inject the drug. So how can we give it? In erector spinae block, it is very easy to perform without ultrasound, and it is with less pneumothorax and hypotension. So what is the mechanism of action? This is a very recent article where they say that if you deposit the drug here, there are some slits in the superior costal transverse ligament. Here you can see this is a gap between superior costal transverse ligament and intercostal membrane, and there is a medial gap also. So drug seeps into the paravertebral space through this gap, and it will block the, it will go inside the paravertebral space, and it will act just like the paravertebral block. It definitely blocks the dorsal root, but with this mechanism, it blocks ventral root also. And another mechanism proposed is it is because of systemic absorption of the drug, but it doesn't last for long. As Amit said, it lasts sometimes for 24 hours. So it doesn't explain systemic absorption. So simple technique. In adult patient, if in paravertebral space we go 2.5 centimeter lateral, but here we go 3 centimeter lateral. So if you go 3 centimeter lateral, insert the needle, hit the transverse portion, and if you inject the drug, it will spread in the erector spinae space. So again, just like the paravertebral block, you have to palpate the C7 transverse process, palpate T1, T2, T3, go 3 centimeter lateral, hit the transverse process and inject the drug. So how to give it? I will show with video landmark guided technique. Here you can see. So initially it was described for chronic pain, but now you know we are using left and right and center for every procedure from shoulder to the hip. We are giving at all levels. So we have to palpate the T5 spinous process. This was for breast surgery. We go 3 centimeter lateral and hit the transverse process and inject high volume, that is 25 ml of LA. So here you can see I'm inserting the needle perpendicular to the skin, 3 centimeter lateral to the midline. This was for surgery. I'm inserting the needle. I am hitting the transverse process. Once I'm on the transverse process, I'll inject the drug after careful aspiration. You can see I'm injecting the drug. I'm injecting 20 ml of LA here. I usually use 0.2% ropivacaine for this block. I use this block regularly for spine surgery, but I'm not fond of this block for breast surgery or thoracic surgery. It provides excellent analgesia for spine surgery as it blocks the dorsal nerve root consistently in all the patients. But I'm skeptical about using this block for breast surgery or thoracic surgery or abdominal surgery. As Amit said, everyone has different opinion regarding this block, and if you like it, you can use it, and if you don't like, forget it. So after injecting the drug, I checked the spread, and it was nicely spreading inside the erector spinae plane, and you can give it easily with landmark guided technique. And this so this is the landmark guided block. Another video is of this was the patient of kyphosis, where we used neurological monitoring also. So here we gave the block at multiple level because incision was very big. They went from upper thoracic to lumbar level. So we marked the level and we injected total 40 ml of LA at different level, and we injected at multiple level, and you can see after giving injection at multiple level, we can do surgery without much of hemodynamic changes. We require less amount of inhalation agent, which is must for neurological monitoring, because they want less than 0.5 mEq, and they don't allow muscle relaxation. So we need to provide good analgesia to keep patient on spontaneous respiration with less amount of the drugs. So we gave this block, and This surgery was done nicely with a block along with a low concentration of sevoflurane and propofol infusion along with fentanyl and dexmedetomidine. Here you can see neurological monitoring is going on during surgery. So this is a nice block for spine surgery. There are some limitations also, like mechanism of action we don't know completely, and it is not understood completely also. Quality of analgesia varies in different studies. Some of the studies will say that it provides excellent analgesia for all kind of surgery, while other study will say that it is good for spine surgery only. Spread to ventral root and thoracic parietal space is not consistent in all the study. Depth again is different at different level. And another limitation with landmark guided technique is this distance between spinous process and transverse process is different at different level. And even in the patient with different stature, like if patient's height is 6 feet, then this distance may be different. And if you go at lumbar level, it is higher, and people are giving at sacral level also. I don't know how far you should go from midline in sacral blocks. Another important block is retrolaminar approach. Here you have to go 1.5 centimeter lateral to the midline. Here you are depositing the drug above the lamina, and again they said through medial slit drug spread inside the paravertebral space. So I'm marking the point 1.5 centimeter medial to the midline, and I'm hitting the lamina, and I'll inject the drug after hitting the lamina. So I'm on the lamina. You can use your IITV also for this block. I'll start injecting a drug, and I will see in the ultrasound machine also whether the drug is spreading in the right plane or not. Here you can see drug is spreading nicely above the lamina, and this is for retrolaminar block. I confirm the needle position with IITV also. We'll see in few seconds. So after injection of the drug, here you can see with ultrasound guided technique, I checked with IITV, and you can see I was hitting the lamina with the by going 1.5 centimeter lateral to the space. Again, some clinical purpose, always do marking with marker pen. Otherwise, you will go either too medially or too laterally. Use needle depth marking. Depth of transverse process varies at different level. Don't advance needle beyond 5 centimeter if there is no contact with transverse process. Relocate your landmark and go. Inject saline to expand the space for catheter. Always attach syringe with needle while locating the space to prevent pneumothorax. So this is about ESB. Again, after stop sharing, I will open my next presentation, that is about sorry. So this is last part of my presentation, that is thoracic block with SEP block and PEX block with LOR and PNS guided techniques. So chest wall blocks, as I said, thoracic paravertebral block is oldest of all technique, and it is gold standard, but newer blocks are simpler and safer. They can be used for breast surgery, chest surgery, thoracotomy. Even for multiple rib fracture, you can put the catheter in the SEP plane, and you can use it for chronic pain also. There are plethora of blocks, like from midline to laterally, you find different blocks, multiple blocks like PEX1, PEX2, MTP block, intercostal block, serrator center plane block, transverse thoracic block. So multiple blocks for are described in last decade, and you can use the block of your choice. Here again, you can see these are the space where they are depositing the drug with various techniques to block the intercostal nerves. So briefly about anatomy for breast surgery, if you look at this is the pec major muscle. Below you will find pec minor, and between that you will find lateral and medial pectoral nerve. So if you deposit the drug between pec major and pec minor, it will block your lateral pectoral and medial pectoral nerve. That is your pec1 block. If you go laterally between pec minor and pec major and if deposit the drug, it will block your long thoracic nerve, and These are the lateral cutaneous branches of intercostal nerve. So with that, you block these two nerves. And if you go posterior in the SAP plane, either with anterior or posterior approach, you will block T2 to T9 lateral cutaneous branches, as well as you will block thoracodorsal nerve that supplies the latissimus dorsi muscle. So these are the various blocks described. Dermatomes, as I said, you should confirm which dermatome you want to block. ESB versus thoracic periapital block, as I described in previous presentation also, I will repeat it. ESB, you hit the transverse process and you deposit the drug. And in thoracic periapital block, you go beyond the superior costal transverse ligament and you deposit the drug. So this is your ESP, and if you deposit the drug here, it becomes your thoracic block. So this is just for revision. So here, if you deposit the drug here, it becomes your thoracic periapital block. I'll skip this slide because we have already discussed this. PNS PEX1 block. If you want to give PEX1 block easily with PEX, when you are giving intraclavicular block, you must have seen contraction of pectoral muscle. So it is just, it is because of stimulation of pectoral nerves. So here what I do is I am going just anterior to the anterior axillary line on the third or fourth rib. I insert the needle. I fill the pop of the prepectoral fascia that is above the pectoral muscle. After filling that pop, I will advance the needle and then I will look for the contraction of the muscle. So here you can see I have kept the PNS at 1.5. I am advancing my needle. I have filled the pop. I have advanced the needle. And you can see the contraction of the pectoral muscle. So once I get it, I'll reduce the current and I will try to elicit the response at 0.5 milliamps. So I'm again readjusting the needle. Once I get this at 0.5 to 0.6 milliamp, I'll inject 10 ml of LA, and that is your PEX1 block. Can you appreciate it? Nice contraction of pectoral muscle. So here you
yes,
can...
Yes, very well, thank you.
Yeah. So this is how you can give PEX1 block with PNS. If you want to give SEP block with PNS, you have to go into mid to posterior axillary line. You palpate fifth and or the sixth rib. Insert. This is anterior SEP block. Here you are going between the latissimus dorsi and serratus anterior muscle, where you are stimulating the thoracodorsal nerve. So here you can see I'm going into the mid to posterior axillary line. I'm inserting the needle and I'm looking the response of the contraction of the serratus muscles. So I'm readjusting the needle and look for the contraction of the serratus anterior. And once I'm in the right plane, you can see the nice contraction of the serratus anterior. I reduce the current, and once I get the contraction below 0.5 amp or at 0.5 milliamp, I'll inject the drug. So here I can see small contraction with 0.5 milliamp also, which is disappearing at 0.4 milliamp, and I'll inject 20 to 25 ml of LA to block lateral cutaneous branches as well as thoracodorsal nerve to give the SAP block. LOR PEX block, it is easy. I'll show how to give it. So palpate the third rib, blunt the 24 gauge needle, hit the rib, withdraw the needle till skin, then fill the pop of prepectoral fascia, advance the needle, and once you get the second resistance between PEC major and PEC minor, you inject the drug. I am locating the rib first. You can see I'm trying to locate. I attach the syringe to the needle so that I don't go inside the pleura and create the pneumothorax. So once I am on the rib, I'll come out and look for the pop of the prepectoral fascia. You can see I'm getting the resistance. Once I go beyond at other resistance, I will inject 10 ml of LA. So that is for PEX1. And after giving 10 ml of LA, I'll inject another 20 of LA after hitting the rib. That becomes your injection between serratus anterior and pec minor muscle, that is your PEX2 block. So I'm on the rib again on the fourth rib, third or fourth rib. I'll inject 20 ml of LA there, and it will block both PEX1 and PEX2. So if you want to give it for breast surgery, analgesia for breast surgery, you have to either go for PEX1 along with PEX2, and you should, or you can go for PEX1 and SAB block. Anterior cutaneous branches are spared. For that you require just infiltration in the peristernal area, and supraclavicular area is also supplied by cervical plexus. So for that you require 3 ml of infiltration just above the clavicle. It will block your supraclavicular branches, that is branches of superficial cervical plexus. LOR SAP block, again, I'll hit the rib and inject the drug. It is as simple as that. So you draw the mid and posterior axillary lines somewhere in between. You palpate the 5th or 6th rib, hit the rib and inject the rib. That becomes your deep superficial serratus anterior plane block. So I'm palpating the rib. This patient was bit obese, so I had to palpate deep to palpate the rib. After palpation of the rib, I'll insert the needle and hit the rib, and then after hitting the rib, I'll start injecting the drug. I will inject 20 to 25 ml of LA, and when I checked with ultrasound, drug was nicely spreading just above the rib. So this is how you can give LOR SAP block. Is there evidence? Now evidence is building. Now we have started publishing the papers. We have this is by me. I published the technique of serratus anterior plane block with anatomical landmark guided technique. I have published ESB also, and there are some now there are some prospective studies also about landmark guided ESB, and it is becoming popular. Same way, landmark guided erector spinal block, as I said, it was published, and now there is a study by, I think, Rashmi madam. This is by peripheral nerve stimulator, and it is by Dr. Ritesh Roy. And you can see, you can give PEX1 block as well as PNS also, and now it is in literature also. But again, don't forget, these blocks are part of multimodal analgesia. These are high volume blocks, so always calculate toxic doses before giving these blocks. I usually use 0.2% ropivacaine for PEX1, I use 10 ml. PEX2, that 20 ml, and for STEP, I use 25 ml of LA. For anterior cutaneous branches, I require just 5 ml of LA for infiltration, and for supraclavicular branches, I require another 2-3 ml of LA. Again, this is my YouTube channel where you can see all these blocks. Thank you. Thank you very much.
Thank you, Dr. Hetal. That was brilliant. And the videos and the techniques are super fun to watch and listen to. I think Dr. Amit has a few slides on success stories, and I'll request Dr. Amit to kindly share his screen.
So I thank you, Hetal and Harshal. I think this was the question by Dr. Shilpa, that why the enthusiasm is not there much with interfacial plane blocks. And this was another article, Daring Discourse by Dr. Hadzik, and even most of the journals are nowadays with a lot of criticism for all these interfacial plane blocks, or in general, like you can see here, the caption is general anesthesia is acceptable choice for hip fracture, or somebody is talking about the phrenic nerve block to an extent that people are worried about giving an interscaling block, or the ESPB block is like a, it's not at all a block, RIP block. I mean, of course, science is how it is evolving the way it is, but somehow it affects or to some extent curbs the enthusiasm of doing these blocks. And therefore, I wish to share, because this was with ESP, our journey has started, and I could see that enthusiasm is slowly reducing. So I am just sharing few of the success stories where we have done this bariatric patient and a landmark guided erector spiny plane block, and patient was just comfortable even up to 72 hours till discharge, and we were very happy This was in 2016, 17, and we have made this one. And of course, data is still emerging. I'm not saying whether it is whether the ventral rami are blocked or not blocked and what is the cadaveric evidence. I'm not going into that details. But whenever I have an opportunity to utilize the regional technique, because in principle it's a beneficial thing, and even we have placed erectrospiny continuous catheters and using a 2 tip needle, and even some of my chronic pain friends also have utilized it, and they have even kept the catheter for 7 days and they have injected the dye. We have introduced ESP block in its initial 2016-17 to everyone in ICU, and they were also very happy, where those patients who have failed trials for extubation or fracture rib patients, and all those set of patients, they have used it, and the intensivists were very happy that they got to know something and they can use it. We have used ESP at various surgeries, and even the ASIS bone graft, the PCNL, the shoulder, the lipoma. One interesting case was this was a patient with lower limb pain, and she has lower ejection fraction and LV aneurysm. So we just provided the 0.2% ropivacaine erectrospiny plane block with landmark, and she could lie down comfortably for this MRI, and we could finish that MRI, and we could see when the drug was deposited at around T12 level, the spread on MRI, we could see on stir sequence that it has gone up to T8 and lower down up to L3. And somehow we are now finding the use of regional anesthesia techniques even in anesthesia in remote locations. So on arrival block, rescue block in wards where epidural has come out, and at least something is better than nothing. And I am sure if we have some of our interfacial plane blocks, it may happen that they are not working well, but we give our best shot, and most of the time we try to find out what is the anatomical correlation, what has happened to the patient, looking at the cadaveric study, and I think it is benefiting. We have regional fellowship programs, so all our laparoscopic patients do get either quadratus lumborum block or an ESP block. We even use ESP for breast surgeries because sometimes the surgeons are not comfortable with X block, as the solution may come in their way. So, of course, we have discussed today many blocks, and I think we have given good stimulation to every one of you to practice it still further. Thank you very much. Wonderful and very good crowd to see. Thank you. Over to you, Hetal and Harshal.
Thank you, Amit, and thank you, Dr. Hetal. I think we'll jump on straight to the questions because almost 9:30. So a few questions that I've already got on the chat box and before as well. I think the question was put before as well. I think the question is probably open to both of you. Is if there is partial action of a spinal in cesarean section, can the day be saved with a tap block? Do you think that's a feasible option?
No, Harshal. Basically, as I said, tap block covers only somatic pain. It doesn't cover visceral pain. So if your spinal fails, you should go directly for GA rather than going for tap block. Or else, if surgery is not started, you can go for repeat spinal if you are confident with. I'll not recommend tap block for surgical anesthesia.
Right. And another question was in terms of...
Sometimes the small subanesthetic dose of ketamine, 1 or 2 levels, if there is receding, it is mentioned in Miller's, maybe titrated aliquots of 5 milligram or maximum to 10 or 15, depending on the weight of the patient, can cover those 1 or 2 missing segments where you are just falling short of as the surgeon is stretching. But as Hetal has mentioned, it is either you have a block which is acting, so you have given a spinal which is acting. There is nothing like half-hearted spinal. People do tend to put mask and then try to ventilate, or they use some CO and all that hodgepodge. I think it is very good idea to admit what has happened and let's be open. And in the safer interest of the patient, it is good idea to convert it to general anesthesia or what he has mentioned, a repeat spinal.
Right. Your thoughts about either a pacemaker insertion or a port insertion in terms of blocks? A port insertion, a chemo port, or a pacemaker insertion.
It can be done with PEX 1, PEX 2, or by combining PEX and SEP. SEP, I will say it is too much for this thing. But if you give PEX 1 and PEX 2 with some sedation, you can definitely complete the surgery with 2 block only for port insertion as well as this thing.
Right. Amit, anything different?
We have tried this. And what we have found is if you have a very good, electrophysiology cardiologist, they or a very good, like even the breast surgeon who does port insertion, if it can be very well managed with a fan-shaped local anesthetic infiltration also. A good LA infiltration can also serve the purpose. We have done one study where we have compared PEX block with local infiltration anesthesia. And at that, we used to wash up in surgical scrub, and we have done local infiltration. And then we slowly explained them the anatomy, and then even the oncosurgeons started utilizing this. So a little bit better knowledge of dermatome and innervation in that area, even good local infiltration should also suffice.
That's true, actually. We also did a few port insertions by putting few mils of local anesthetic in the superficial cervical plexus, because that's where they put the pocket of the port. And a little bit of sedation, I think that, and local infiltration works fine.
One of our oncosurgeons is doing it regularly. He does all the ports under local anesthesia only with some sedation.
Correct. Other couple of questions were: any additives to the facial plane blocks? Does hyaluronidase make any difference in terms of facial plane blocks, and whether dexamethasone, or do you add anything, adjuvants?
In my practice, nowadays, if you talk about adjuvants, there are hardly few adjuvants left which are still being used. And one of them is dexamethasone, another is dexamethasone. Sometimes people use clonidine and buprenorphine. In my practice, we do add dexamethasone. Again, this is one more area where there are the regional anesthesia groups are divided. They add adjuvants, they do not add. They say we give IV, we give. There is no for perineural. But of course, we have multiple articles, and if you, as Hetal was showing, the ESPB article, the erector spinae article, and even the other interfacial plane block, people have used, dexamethasone, and it has nowadays with brachial plexus block and all, it has mentioned that it can prevent rebound pain or something like that. And whatever few hours now, different papers will have different results. One group from, I think from ESRA group, Dr. Sebastian, he is of the opinion that we can use IV also and perineurally also. I think so long as adding this drug, whatever benefit, if it is not harming the patient, we can add. But if you don't add, it's quite all right. Usually, most of us have aim when we plan for a block. Most of us, at least in my institute, we use it with ultrasound, and we open these needles. Most of these needles are, if it is a nerve block. Interfacial plane block, we can still use a hypodermic needle, but when we are near any nerve, our suggestion is to use blunt tip or a PNS needle, and these are 1,500 rupees. The ultrasound is a chargeable item, and if we are using all these, then probably we should plan our anesthesia in such a way that it should provide some pain relief for more than 24 hours, if not less. So some group of anesthetists, they use extremely low volume, very low concentration, no adjuvant and nothing. And then they do that block, and then their block wears off because the total dosage is very less, and it wears off in 5 and 6 hours. Then this is equivalent to local infiltration analgesia up to 6 hours. So definitely most of us would want our patient to be pain-free, at least on the day of surgery. The night should be pain-free. And if we are in the opinion that we should not be using adjuvant, then putting a catheter is a good idea, or repeating the block next day. Some blocks like rectus sheath block or a ESP block, we can definitely repeat the next day, and people are doing it that way as well. And you can do it even in a low resource setting. And as an acute pain physician, we are responsible for at least 72 hours of pain management. So the patient has moved out of body and is pain free. Probably we should look in at least next day or at night, when they're even much more challenging night hours. We should have strategy and back of our mind. Hetal may share his opinion. Yeah. Thank you.
Dr. Hetal, we've got a couple of questions which are sort of similar in terms of location or finding the landmarks. So one is there any way to find out the difference in the transverse process and the rib in terms of landmark wise? And the other question which is similar is transverse process in relation to the spinous process in thoracic levels may not match. Is there any specific things that you do to locate them?
Usually with landmark guided technique, it is difficult to differentiate by feeling. But if you look at the distance we are using, we usually use, like if it is paravertebral block, we will go 2.5 centimeter lateral to midline after palpating the spinous process. For erector spinae, we go 3 centimeter. So if you go up to this distance, most of the time it is transverse process. If patient is small, you can make some changes, like if it is too short, or if patient is pediatric, you can go up to 1.5 to 2 centimeter. And another difference is if you look at the rib, it is bit superficial as compared to transverse process. So if you find the transverse process in a regular build patient at 2 to 2.5 centimeter, usually it is rather than transverse process. So if you find the bony landmark at 2 to 2.5 centimeter, go a little bit more medially and try to find out transverse process rather than injecting the drug there only.
Right. And Amit, you also mentioned that, I mean, for breast surgery as well, we know that the nerve supply is from various plexuses. So is there a point or an argument to give an interscalene block to cover parts of the brachial plexus? Is that something that you would consider? Or, I mean, even Dr. Hetal can answer that. What do you do in the routine?
No, actually speaking, it is too much for breast surgery because we want to block pectoral nerve only. So when you can block pectoral nerve easily by giving PEX1 block or with PNS or without PNS, with landmark guided technique, giving interscalene block and making patients upper limb numb, I think I will not do it in any of my patients.
Actually, I'll share my experience about the case series which we have published, and that's an ongoing process where we have come to close to 100 cases with, for high-risk breast surgeries done under sort of combination of blocks. And we went through the whole gamut, and we started in 2015. So we started with the thoracic paravertebrals and when the ESP came along. So in fact, we have also realized that the ESP does not give as much as a surgical anesthesia as a thoracic paravertebral does for, as dense an anesthetic, surgical anesthetic as much as erector spinae as of now doesn't do as much. That's what we have realized in our case series. The other thing was this point is, there is an argument where some people have advocated putting some sort of brachial plexus block, like an interscalene or an infraclavicular to cover those pectoral branches. But our patients are not very happy with a, numb limb for a breast surgery. So then we stopped doing that and we started doing only the PEX 1 and PEX 2 separately, as we would normally do a chest wall blocks. Amit, anything different here?
Yeah, actually, as I have mentioned in my initial slides, how the regional anesthesia is moving ahead about the buzzword. So in the era of site-specific, procedure-specific, and another word we have used is motor sparing. So we want to move more and more towards periphery. So again, blocking the pectoral nerve little proximally with a brachial plexus block will cause, insensate limb. My good friend, Dr. Shiva Shanmugam, uses this block, and his argument is, anyways, the patient is in that difficult position for quite some time during the breast surgery and axillary dissection. So they do this block, and sometimes the volume can be reduced very well. Like, for example, thoracic paravertebral at multiple level in 10-15 ml, and maybe a supraclavicular block where medial and lateral cord are blocked in a supraclavicular or an infraclavicular approach. And we can get away with less volume of drug, because otherwise we have to use combination with PEX or SAP, and then there is also again paravertebral on board. So chances of local anesthesia systemic toxicity is another concern. But definitely, if we are planning in some patients, I think in some selective subset where we are worried about last, we can counsel the patient and do it by explaining it to our patients. This is another choice, but routinely, in my practice, I haven't done it because it's very difficult to explain. No procedure in regional anesthesia is free from risk. If something happens to that limb because of whatever reason, it is very difficult to explain that sort of issue. Yeah.
And I think we would agree that the chest wall blocks, especially for breast surgery, is better to be done pre-operatively rather than post-operatively, because post-operatively, obviously, the planes are disturbed and it might be difficult. Do you agree with that, Doctor?
Yes, I agree with you. But in our practice, we have stopped doing PEX 1 block almost in all cases, because when you deposit the drugs in the plane between PEC major and PEC minus, once a surgeon reaches there, their plane is disturbed, and they are not happy seeing some drugs inside their plane. And sometimes even usage of cautery is becoming difficult. So we have stopped using PEX 1 block in our patient. We either use thoracic paravertebral block or to provide analgesia in our patient. So
actually,
we have almost...
we actually have exactly the opposite. Our surgeon is quite happy to see the local anesthetic, so he knows that the block is working.
So it depends on patient.
Yeah, so it depends on the surgeon.
Yeah, the plane dissection and everything also opens.
We are also happy that the block is gone in the right place.
Correct.
Right. Any tips on how to find linea semilunaris by landmark? Is there anything that's one question someone has asked?
No, actually, when I give subcostal tap block, one injection I give anterior to the 2 to 3 centimeter medial to the anterior axillary line. So it is between transverse abdominis and internal oblique, and another injection is for rectus sheath block. So I give 2 separate blocks when I am giving with landmark guided technique, especially subcostal tap block.
And I think you answered about in your talk about the maximum dose of local anesthetic, and you probably mentioned that. There are a couple of questions about erector spinae block and anterior surgeries, like nephrectomies and thoracotomies. And I think we all agree that it may be a good option in terms of post-operative pain relief, but I'm not sure about the surgical anesthetic bit.
Yeah.
Am I correct in understanding that?
Correct. Yes.
Yeah, because there are a lot of still controversies about whether the drugs actually does seep through. A lot of people are saying in their literature that it might be just absorption through systemic absorption. So I think the literature is still sort of controversial in terms of one against each other? We still don't.
Once in a while, you can get away with some high-risk case with ESP. The advantage with ESP is less of hemodynamic perturbation as compared to a paravertebral block, and be used in a borderline, patients with borderline coagulations. So, all those VATS procedure and septic patients, and you need to do something, but you cannot do much. You don't want to tube the patient because difficult extubation. Some patients we have tried, but then you need to sort of train your surgeon, the OT environment, the nursing staff. We have done secondary suturing in some patients with lung eventration and diaphragmatic issues, and we do not want to give GA to that patient. And we have done ESP, and somehow it worked in that patient. But there should always be plan B. In some VATS procedure, we have used ESP, we have used intercostal nerve block, and in some patient it worked wonderfully well. In some, we were absolute.
It's inconsistent.
There is no block, thing like that. So there is no consistency with the spread of the drug, and there are multiple factors to it. So when we want a sure shot block, we really depend on something like epidural or a paravertebral or ESP. Probably the ventral rama issue is definitely there. For surgical anesthesia, anyways, interfacial plain blocks are not meant. But CAPD catheter insertion under TAP and quadratus lumborum, we have done it under local infiltration. Sometimes vertebroplasties on ESPs, and even so once in a while, in very, very high risk, explaining everything. We also give some local anesthetic solution, calculating the dosage to our surgeon, and then it's a team effort, and we just finish the procedure. So it's not the popular choice, but once in a while, it can be a rescue measure. That's it. We were doing one nephrectomy, and suddenly the catheter has come out, and then we have to do some block. Then probably in that elderly 75-year-old lady, we have done an ESP, and it has provided us some margin, because reinsertion of epidural catheter in ward is very tricky. So I'm saying just like something is better than nothing, and you have to be watchful, and it is always with combination of multimodal.
Hetal bhai, I know you usually nowadays you have the ultrasound, so you're checking your blocks after doing them by landmark guided techniques. But say you didn't have, or maybe before you had the ultrasound, what would you say you would put levels in terms of causing a complete sort of anesthesia on the hemithorax? The number of levels, either you would do a thoracic paravertebral or a say ESP. Would you do it at multiple levels? Say you don't have the ultrasound now, but what would you normally do?
As I said during my presentation also, if you don't have ultrasound, I will like to go for multiple level thoracic paravertebral block. I have done many awake surgery with thoracic paravertebral, especially breast surgeries with thoracic paravertebral block. What I was used to was I was giving block at T2, T4, and T6 level, and with that, most of the times patient was getting good surgical anesthesia. I was supplementing with a supraclavicular block. I was just infiltrating 3-4 ml of LA above the clavicle to take care of upper part of the breast that is supplied by supraclavicular now. So it was taking care of the patient. At the time of axillary dissection, sometimes I needed a small dose of ketamine, like 25 milligram of ketamine, and it was all done under block in most of the patients.
There's a question about the posterior tap and fascia transversalis plain block. Is that possible under?
No, it is difficult to give it with landmark guided technique. It is with ultrasound only. Even QL blocks.
Right. And I know you mentioned, and even Amit mentioned in that. So using ultrasound, we are a little bit more confident in giving these blocks in patient, who are borderline on Clexane or, or borderline coagulopathic and all. Do you have that worry when you're doing it by landmark technique, or would you use the same sort of guidelines?
Yeah, we can use it, but I have seen a hematoma in a patient with low platelets with TEP block. Because we are using blunt tip needle that is blunted with different techniques, sometimes these needle tips are very blunt. and it will tear the muscle rather than piercing the muscle if it is too much blunted. So in such cases, there are chances of development of hematoma, and I have seen one patient of hematoma between internal oblique and transverse abdominis muscle with TAP block, where I used this landmark guided technique, and patient had borderline platelet count like 70, 80,000. So I'm a bit skeptical using this blunt tip needle, which I have formed in such patient. I will like to use either pencil point needle or regular block needle in such cases, even if I want to do it with landmark guided technique.
Even the conventional teaching, what Hetal has already shown in the video, as far as landmark guided blocks with Ganga practice, which is for the technique was devised by late Professor Dr. Ravindra Bhatt. He has always emphasized when you want to do a blunt, create a blunt tip, you have to tap only once the hypodermic needle in the vati, what that vessel, sterile vessel, what Hetal has shown. The Dr. Bhatt would say tap only once, and then you actually closely see the tip of the needle. You don't find any curve there. But once you do several tapping, you will eventually see a lot of curve, and then it has become much more blunt, and probably the issue of tearing the muscle that will happen. So just tap only once, not much of force. That is enough to appreciate pops and all those giveaways.
A couple of questions about pediatrics. Would you say that the indications are pretty much similar to in pediatric patients as well? Obviously, we need to keep the maximum dosages in view, but otherwise the indications, say for an ESP or would be pretty much similar for adults as well as pediatrics.
Yeah, it's same.
Yeah. Pediatric patient here, the ESP description, they say instead of 3 centimeter, it could be 1 centimeter.
Yeah, 1 to 1.5.
Another important point is most of these babies will have X-ray, and you can look at even the X-ray will tell you the transverse process placement, where exactly is the thoracic vertebra and how far is the transverse process. And you can use that clinical knowledge of, the visualization of chest X-ray and apply it while you are doing an ESP block for these kids. And volume calculation should be very proper, and we should not overdo it, and less margin of error. Roughly for any interfacial plain block, volume can be from 0.3 to 0.9 ml per kg as maximum what they have described. But most of our block will have 0.3 to 0.5 milligram, ml per kg. Say, so for a 10 kg child, probably 10 into 0.3 or 10 into 0.5. So 5 ml is good enough dose. And we should be careful while injecting, aspirate, inject very slowly.
What about catheters in facial plain blocks? Are you doing them sort of regularly or?
So for rectus sheath catheters, we have placed ESP catheters. We have used quadratus lumborum catheters, the anterior and all that, anterior quadratus lumborum block. And even we have placed SAP catheters. And so we have used a bit of catheters. You have to have the indication. As far as SAP block and ESP block, where we have a bony landmark, it is easy to use a 2E tip needle, and we can pass on the catheter very well instead of using that Contiplex set. A 2E tip needle can appreciate and we can hydrodissect that space and pass on the catheter. And we can check that catheter by injecting the dye. Most of our urologist friend that dye is available anyways, they are using for urology. We can use few mLs from there, and we can have a C-arm shoot, and we can see the position of catheter. By and large, if you look at the literature with catheter placement, by the 48 hours, the catheters are supposed to displace. So it is not highly desirable to keep those catheters beyond 48 hours. But in some patients with some of my friends from chronic pain and all those, They have used ESP catheters for as long as 7 days. It has worked well with them. So you have to keep on checking. We have to keep on assessing hypoesthesia, the drug when it is injected, hot and cold sensations. So proper analysis, documentation, follow-up at the local site. There should not be any induration, maintenance of good sterile dressing. And intermittent boluses are better. There is good literature evidence to suggest that we should use intermittent boluses than continuous infusion. There are articles on thoracic paravertebral block where more dermatomes are covered if we use these intermittent boluses. We do have advanced PCA pump where there is a facility of automated boluses. So program intermittent boluses, and we have used it once for thoracic paravertebral, and it is a good technique, but of course some cost is involved, and we need a very selected group of patients to look after and maintain those pumps very well. But it's a upcoming area, and I'm sure with better and better acute pain services, we are looking forward to use of more and more catheters in interfacial pain.
I've used ESP catheters in multiple rib fractures, and it works well. Probably mechanism are both like some of the drugs spread in the paravertebral space and it works. And I feel that there is some role of systemic absorption when we are putting ESP catheters. So when you start a continuous infusion, plasma level of local anesthetic will remain in the range where they provide systemic analgesia also. So I found that ESP catheter works well in multiple rib fractures.
There were a couple of questions about QL block, Hetal bhai. Any thoughts on those? Whether
no, QL block is difficult to give with landmark guided technique. It is better to give it with ultrasound guided technique only.
Right. I think we have probably gone through most of it. There's one about whether I know the abdominal wall blocks. Well, most of them are all sort of somatic. QLs may probably give you some sort of visceral pain relief. But do you think a paraumbilical hernia or a small hernia can be possibly done under these sort of rectus sheath or a tap block if bowel is not involved? Is that possible? Or?
It can be done, but you require some sedation. I observed that when they handle the sick, patient will have some pain. So if you give some dose of ketamine or midazolam fentanyl, it will take care of it, and you can definitely do the surgery under blocks only, especially when the hernia is of small size.
Small size. Right. I think you've probably gone through any. Tendulkar sir, have I missed any questions? I think
I guess you have covered comprehensively.
I think one last. I think can you discuss any recent advances or innovation in the field of chest wall blocks and abdominal wall blocks? I think we have gone through that.
This external oblique intercostal block at just anterior axillary line at T7 probably will cover the open cholecystectomy where in resource limited setting where their laparoscopic facilities are not available. Most of these patients will have open cholecystectomy, and I think a good block in the anterior axillary line at T7 probably is a good idea because once the incision is taken, it is difficult to do a subcostal tab or any other block in that area. So if not paravertebral, then probably we can do this block as well.
I think as a general rule, if possible, we should try and do these blocks before the incision for multiple reasons. One is obviously the anatomy is not distorted. That is one. Two is I think by the time the blocks work when the patients wake up, they're probably better. I mean, if you do an audit of your blocks, the patients that have had the blocks pre-operatively wake up much better than the ones which have had post-operatively, because by the time the block time takes for the blocks to act. That is true.
Yeah. Please continue.
And you can get. And the third one is I think that the concept of about the receptors are not activated before this. So if you basically what I mean to say is when you're given the blocks and the incision is taken once the blocks are done before, then the pain cycle that is activated is not done. Whereas if you give it after the incision is taken, then the chronic pain concept comes into view. So I think multiple reasons to give those blocks before rather than post-operatively if you can. Obviously, if there is no option, then it's a different thing. Yeah, sorry, Amit, you were saying something.
I think Amit has gone offline.
Yeah, Amit, I think has
disconnected.
I think you've pretty much taken all the questions. Dr. Shilpa, anything?
No, it was so extensive, and I'm really grateful for taking your 3 hours on a weekday.
Yeah, really. I think they've done very well.
Yeah. It was so much extensive, my God. So, Tendulkar sir, can we have a vote of thanks?
You've given a choice, then I have to.
Can we conclude, Tendulkar sir? You still want to ask something?
No, I think we can conclude. I think you can start with the vote of thanks, man.
Yeah.
Only thing I would like to add, if you may allow me, that we freelancers should be thinking more about post-operative pain relief and not only about just intraoperative period. We need to learn all these techniques and practice every day so that we can do better justice to the post-operative pain relief demands of the patients.
Yeah, we mostly don't think about it and leave it on the surgeons.
Yes,
whatever
exactly.
They prescribe. Yeah.
Exactly.
Yeah, we need to move from anesthetist to perioperative physician.
Yes.
So at
freelancers, especially freelancers.
So at the offset, I thank Dr. Amit Dikshit sir, Dr. Hetal Vadera sir, and Dr. Harshal Wagh for giving excellent insight of the anatomy, telling us different block techniques. I like the schematic videos, the actual anatomy videos of Amit Dikshit sir, the schematic videos of Hetal Vadera sir, and actually blocks on the patient. It was so much in detail. Like actually, I saw the serratus anterior and pex block after a long time. And maybe the serratus anterior block, I'll definitely try by loss of resistance. Because the moment, there is always a block from the surgeon also. The moment I get the sonography machine, "Arey madam, kyun chahiye? Thoda sa all analgesia de do IV." So I think if I just deposit the drug by loss of resistance or landmark, and my patient will be better, I don't know, and my satisfaction will be better. So I thank all 3 of you for taking time on a weekday and really working hard to tell us all these details. Rao sir, any inputs?
Can I say something?
Yeah, please.
It is a pleasure and privilege to have Dr. Shivkumar Singh as one of the participants in this event. Thank you, Dr. Shivkumar.
And we have Dr. Shri Krishna Joshi also.
Yeah.
Thank you, sir, for joining. Ankita, now you can unmute everyone.
Very much. Thanks a lot, everybody. It was an excellent.
I think.
Thank you.
Thank you will be a very small word for all that knowledge and all the slides and the videos. And thank you so much.
Thank you very much.
Thank you so much,
everyone. Thank you,
Shilpa. Sir.
Thank you, everyone. Thank you.
Thank you so much, everyone. Thank you for sharing such valuable insights and for being with us. Thank you for so much cooperation. So with all your permission, can we conclude the session over here?
Yeah, we can.
Thank you.
Thank you, Hetal Vadera sir. Thank you, Harshal. Thank you, Amit Dikshit sir.
Thank you. Good night, everyone. Thank you.
Good night.